Good afternoon. Welcome to the Senate Finance Committee. Today's Tuesday, January 21st. I'm going to do a little arranging in the agenda, if it's okay with everyone. We're going to start with the AHEAD model implementation with the Department of Health and the HSCRC, the Health Services Cost Review Commission. And then I'd like to go to the Maryland Hospital Association and hear from them about the AHEAD model so that we kind of have the same subject together. If that's okay, if there's no objection from anyone, that's how we'll start. So thank you very much. If I can have Secretary Laura Herrera-Scott and Dr. John Crom come to the table, please. We're going to hear about the AHEAD model implementation, and thank you both for being here.
Good afternoon, everyone. Can you hear me okay? Good afternoon, Chair Beidel, Vice Chair Hayes. Thank you for having us today. I'm going to start. We're going to do a tag team presentation on the AHEAD model. Where's the clicker? Oh, okay. Oh, that's new. Perfect. Yeah, way better. Thank you. When we first started talking about the total cost of care model, when I came into the role of Secretary of Health, one of the things that was flagged is really having a vision for healthcare in Maryland and what did that look like and what was the role of AHEAD in that vision. And a few of us locked ourselves in a room, had a whiteboarding session, and this was the way we were thinking about it as we thought about the continuum of care. So ensuring a world-class health system for all Marylanders that was focused on equity and excellence in healthcare delivery that improved healthcare for all. And this is the continuum of care as we think about going from upstream supports in the community that address health-related social needs, primary care, specialty care, hospital care, and then on the post-acute side, post-acute care, and then as we get into end-of-life care, palliative care, and end-of-life care. And throughout all of this, again, the focus has been data, which is not listed here, certainly equity, community, and population health. So this is some background and where we are today. So the Maryland health model, so we've had an all-payer hospital rate setting system that's been established since the early 1970s. And then in 2014, the global budgets was established, and then the total cost of care model started in 2019, and we're still under the last negotiation. So as you can see here, the AHEAD model does not kick in until next year, calendar year 2026. And what are the strengths of the Maryland health model? So enables cost containment for the public, ensures all payer hospital charges correlate with costs, guarantees equitable funding of uncompensated care. I think you're all familiar that we do not have any safety net hospitals in the state of Maryland because of the model. Creates transparency and cost savings for the public and stable financing system for the hospitals. Funds investments in population health, and some of that has been done through the HSCRC and the regional partnerships. Provides support for pioneering state healthcare infrastructure and subject matter expertise. Certainly incentivizes care transformation across all settings of care, and then invests in primary care, and lastly, has allowed for innovation. So under the total cost of care model agreement, that was certainly key to Maryland's all-payer rate setting authority and is authorized through December of 2026. When we first started talking about the next steps, knowing that the model was ending in a few years, CMMI certainly signaled that the AHEAD model, or the all-payer health equity access and development model, was the way forward for Maryland to continue its model, which was just building on population-based payments. And then the AHEAD model allows us to continue as well as expand on its long-term commitment to statewide improvements in healthcare quality while controlling costs. So these are some of the things that the model was designed to do on the left. So curb growth in healthcare cost spending, and we've had total cost of care growth targets. In the last negotiation, there was improved population health with significant investments in primary care, as well as advancing health equity by reducing disparities in health outcomes. So equity and population health targets. And similar to the Maryland total cost of care model under AHEAD, we will be working with our hospital partners, expanding on primary care as we include Medicaid in the model. Previously, the model has been focused on Medicare beneficiaries under MDPCP, but now we will be including an advanced payment model with Medicaid participation, and then focus on population health and health equity. And that's not just for the state of Maryland and having a statewide health equity plan, but in partnership with the hospitals, also having hospitals' health equity plan that feed into the larger statewide vision. This was part of our submission to CMMI, again, to empower all Marylanders to achieve optimal health. We wanted to ensure that it was high-value care, aligning public and private investments where it made sense, enable innovative models, constrain the all-payer total cost of care growth, which Maryland has successfully done year over year. Improve access to care. So again, the inclusion of Medicaid in the advanced primary care. Support statewide efforts to strengthen the behavioral health continuum of care. So in this iteration, behavioral health is included as we think about whole person care. Increase all-payer primary care investments. So I said that was happening under MDPCP through the last negotiation, and now we will be making investments in primary care for Medicaid with enhanced E&M codes, E&M rates, as well as dollars for care management and quality improvement initiatives. And then promote health equity, identify and address health-related social needs and their contribution to costs, invest in community capacity building, and then, as I mentioned previously, under all this, data and analytics, workforce, where we have a lot to do. Maryland did not bounce back like other states did in people leaving and coming back into healthcare, information technology, and what we've heard from the providers over and over again, administrative simplification. We've made it all too complicated to navigate the healthcare system. So with that, I will now turn it over to Dr. John Crom to give more background from the HSCRC perspective.
Thank you, Secretary. So I want to spend a moment, excuse me, talking over some of the things that are both features of the AHEAD model, but importantly, to start from the perspective of what does the AHEAD model preserve, right? So there are certain aspects of the current total cost of care model that are really critical aspects of our healthcare financing landscape here. First and foremost, Maryland receives an additional $1.7 billion in federal payments for Medicare and Medicaid patients. This is a key aspect, right, of our all-payer rate setting system and the flexibilities that we have given to us by waivers of Medicare payment rules, right? This is incredibly important, right, for healthcare financing in Maryland, and it does a lot of the things that the Secretary mentioned in terms of enabling uncompensated care to be equitably funded across payers and hospitals. And then it also ensures that hospital rates for public payers, Medicare and Medicaid, are higher than rates at peer hospitals nationally. Why is that important? Because for a hospital to understand that to know that a patient, they're going to be reimbursed equally for a patient coming in with Medicare coverage as commercial coverage. That's really important for equity across the state, right? In terms of things that the AHEAD model will do further than the total cost of care model, first, it helps to establish a statewide health equity strategy. It helps, again, to further fund investments in population health so we can kind of take the next step forward in a statewide coordinated population health strategy. It continues improvements in healthcare affordability, right? So it continues savings growth over time. It supports state healthcare delivery infrastructure, right? So we have, the ability to invest in certainly primary care, acute care delivery, and then provides the state with access to critical data. We rely on our pretty advanced data infrastructure in the state in order to certainly run our programs, but really have a grasp of total cost of care that other states don't really have. What I would say, though, here is that preserving the characteristics on the previous slide is of the utmost importance. Losing those would place the entire healthcare delivery system at critical risk, particularly acute care delivery, and particularly for Marylanders who receive their coverage through Medicare and Medicaid. But it's important to note that the AHEAD model doesn't inherently solve all healthcare finance challenges, right? So the healthcare delivery system faces other risks that the model doesn't explicitly solve for, nor does it explicitly restrict a state from developing solutions for, right? So these are things that we're going to have to work on as a state in parallel to AHEAD implementation. So for example, nationally, the cost of physician coverage for hospitals is rising much faster than other hospital costs. The AHEAD model doesn't necessarily provide new tools for states to manage this cost pressure, but it's a critical challenge certainly facing hospitals here in Maryland. So while physician costs are not a regulated hospital cost included in hospital global budgets, the HSCRC is working with hospital partners to collect data on this cost driver literally as we speak, so that we can better understand this cost pressure within Maryland, and then work together as a state on solutions that'll be important for the long-term sustainability of our hospitals. So that's an example of something that's not inherently solved for by the AHEAD model, but the flexibilities that we have under the model give us real opportunity to design solutions particular to Maryland. I also want to touch for a moment on the state agreement. So the state agreement is the way in which we memorialize our relationship with the federal government. It creates a framework for partnership between the state and CMMI. It memorializes CMMI's commitment to those all-payer hospital rates. And it preserves, importantly, the state's authority to set policies to manage hospital global budgets, population health, the primary care programs, and health equity. That's really important because I think, again, the AHEAD model doesn't inherently solve all challenges, but that flexibility, it doesn't lay out our global budget policies, but that flexibility will allow us as an agency working in partnership with our stakeholders to really continue to evolve our policies here within the state. We've actually started what will be an extensive stakeholder-involved process to review our core hospital global budget policies and strengthen our model in advance of AHEAD. In particular, what we're trying to do is ensure that global budgets support access to acute care services commensurate to the evolving needs of our regional populations. And we want to make sure that our policies 10 years into this model adequately adjust hospital revenue as patients move from hospital to hospital, right? So these are the types of policy levers that are not specifically enumerated in the state agreement, but instead the state agreement gives us flexibility to work on those as a state. Just want to show a timeline here that reflects the work that we need to undertake over the next year to set targets required for AHEAD implementation, and the Secretary will discuss some of this in more detail. The timeline, I think, reflects the real rapid pace with which we needed to move in order to secure, preserve those features of the Maryland model that I discussed. It was critical that we worked with CMMI leadership that were in place under the previous administration, who really recognized and were familiar with everything that Maryland has accomplished under the current model, and that had an understanding of the flexibility required to continue to make progress on affordability and quality. What it doesn't show is a couple things, right? One is the work that the department and the HSCRC did really to work with a broad range of stakeholders to understand, well, what were the key provisions of the current state agreement and the current model that we would really need to preserve in order or change before we engaged in negotiations with CMMI. That process really helped us identify a set of priorities that we brought into those negotiations. So first and foremost, of course, that we needed a reasonable and moderate rate of expected Medicare cost growth containment. It also doesn't reflect, again, that timeline of policy work that we're going to do at HSCRC and work that the department is going to do to, in parallel, manage some of these other and address some of these other cost pressures on the healthcare delivery system.
Thank you, John. So I'm just going to quickly pivot now to the Maryland Commission on Health Equity. As part of our plan, should I continue? As part of our plan, we did have to establish a governance structure for some of the work that we're doing, especially as it relates to quality and equity targets and a statewide health equity and population health framework. And so when we started the discussions with CMMI last year, they told us, even though we hadn't seen, or it was actually in the notice of funding opportunity, that we would need a governance structure in place for the agreement. And so as we looked across commissions and committees that were already in place, based on the description in the NOFO, the Maryland Commission on Health Equity hit many of the expectations for that work. And so last year we worked with the General Assembly to add more clinical people onto the committee, from anyone from hospitals to federally qualified health centers, the Health Services Cost Review Commission Executive Director, the Deputy Secretary of Healthcare Financing, the Maryland Healthcare Commission, and others to start thinking about the AHEAD model. And then we rolled off some of the less clinical cabinet secretaries as part of this work. I want to add that we increased the membership from 26 members to at least 33 members. There are 2 named hospital representatives, as well as the Maryland Hospital Association. This is a little template of all the work that's underway, is certainly thinking about the state health equity plan, who are our partner as we think about community. It's local health departments, local health improvement coalitions, local behavioral health authorities, certainly our healthcare delivery system, with hospitals being one of the biggest providers there, and then our payers to ultimately get to population health action plans at the local level. CMS has provided a template for the state to use for its state health equity plan. It identifies 5 key parts, mostly focusing on health disparities and population health focus areas, sets measurable goals to reduce disparities and improve population health, identifies evidence-based strategies to do this work, informs plans for allocating resources, and develops processes to include stakeholders. So CMMI has been a little more prescriptive than we thought in the original negotiations, so we're working with the guidance that they've provided through MCHE to move this work forward. These are the 5 domains that they want us to focus on: population health, prevention and wellness, chronic conditions, behavioral health, and then healthcare quality and utilization. And they did make a 6th domain optional, either focus on maternal health outcomes, prevention measures, or social drivers of health. And because of all the work that the HSCRC has done in partnership with the Maryland Department of Health, especially Medicaid and public health, maternal health outcomes is where we're leaning. To inform all this work, we have established a data advisory committee, and these are the different members of that committee. They're kicking off this month, and they are starting the work to look at all our data that not only looks at chronic conditions and total cost of care and spending, but then looking at that by race, ethnicity, geography, since we know there are geographic disparities in healthcare and healthcare access and utilization. So that work is just starting now, and the Data Advisory Committee will be informing the larger commission not only on quality measures that we need to be looking at, but then also dashboards as we look to move the needle. So with that, I will pause. That's the end of our formal presentation on AHEAD.
Thank you, Madam Secretary and Dr. Prom. We're going to have some questions with you first. So, Senator Kramer, you have a question?
Thank you, Madam Chair. So going back to the AHEAD model and its implementation, what are the costs associated with that for our hospitals in the state? What figures have you been?
So the incremental costs of sorry, help me understand.
Are there costs that will be associated with implementation of the AHEAD model? Are there costs associated with that?
So there are increased investments in primary care. The MDPCP under the prior negotiation period was that those investments are coming from the hospitals to invest in MDPCP, but under Medicaid now, the state and the federal match are for the expansion of Medicaid's participation in primary care. But as far as actual expenditures related to the AHEAD model, there are no net new expenditures related to the model.
So the hospitals are not going to be seeing any increases in their costs as a consequence? I'm just trying to get a handle on that.
Yeah, so one thing that we did recently at the HSCRC was we did, as part of frankly an unprecedented adjustment to hospital rates, was we did set aside a one-time $25 million tranche of funding that would be used as a seed fund to help.
That's across, I apologize, I didn't mean to interrupt, but you said 25 million. That's across every hospital statewide?
That's in rates. So yes,
Right.
Across every hospital statewide and across all payers.
A grand total?
A grand total, yes.
Okay.
Yeah. And that's one-time funding, right? And so currently that's the only kind of incremental kind of cost. So, today, right, we have a quality program, for example, and it requires reporting, et cetera. Those will continue and they will likely evolve, right? But those are not incremental new costs for the AHEAD model, right? These are kind of existing costs that will continue.
And the Population Health Trust is to support the hospitals achieve the total cost of care savings. So one of the things, up until the actual negotiation, we were meeting with hospital partners monthly and getting feedback on the model. And one of the things, at least I heard from the hospitals in the city, is that there was a core set of individuals that were using many of the hospitals in the city. So as we thought about those people that have increased needs, health-related or complications of their chronic conditions, that was the basis for the Population Health Trust. And how do you invest in, let's say, I don't know, we have diabetics in a particular zip code that are having access managing their sugars for a variety of reasons. How can we build an intervention that helps manage those individuals in their respective communities? And so we are framing that out now, and there's an expectation to have a return on investment back to the model and the hospitals that are participating. But our hospital partners will be vetting that framework once we've completed. We're still developing what that looks like.
Okay. Thank you, Madam Chair.
Thank you. Senator Gallo, you're next.
Yeah, thank you very much, Madam Chair. Secretary Laura Scott, I was just, thank you for this presentation. I was looking at the slide where it has the membership composition of the Commission on Health Equity, and it's pretty large. And I note that the vast majority of which are state employees and just a few representatives bringing a hospital voice. I'm wondering if maybe you could provide some reassurance to this committee that the commission is nimble enough and that there is sufficient expertise regarding hospital operations and finance to provide meaningful input.
So it has 2 hospital representatives on it now, and then, as I said, the MHA, Maryland Hospital Association representative, but the language in the law says at least. In conversations with the Maryland Hospital Association, we've offered up at least 2 other seats, but again, we're just trying to make sure that there's balanced voice at the table. So out of the 33 seats, having 5 of them is a pretty significant percentage. But we've already offered up 2 additional seats. But again, it says that that's the minimum. We can have more based on what we're discussing.
So two more have been offered, but just haven't been
2 more have been offered.
and haven't been filled. Is that or maybe?
The 2 were offered. We haven't gotten feedback on what that looks like and which hospitals would be filling those.
Okay, all right. Thank you very much. Thank you, Madam Chair.
Thank you, Senator. And Senator Ellis.
Thank you, Madam Chair. Thank you, doctors, for your presentation. On page 15, the State Health Equity Plan components.
Is that the slide?
No, that's not the slide.
This one.
The 5 core
Oh,
domains.
yes. Yep.
Yeah. Yeah. Great. Thank you. So could you go a little deeper into the optional domain and why those issues are optional, and what does it mean to be optional when it comes to actually the, I guess, mandatory domains?
So these are prescribed by CMMI. So CMS has said 1 through 5 you have to do, and you have a choice for number 6. So it's not optional in that we can't pick any of them, but they want you to pick one, and it was one of those 3: maternal health outcomes, prevention measures, or social drivers of health.
So you have to do the 5?
We have to do the first 5, 1 through 5,
Yeah.
and we have to pick one from the
pick one.
optional list. So we
Okay.
technically have to have 6 domains.
Okay. So out of the choices, which one do you pick?
We're leaning towards the maternal health outcomes just because the department and the HSCRC has done so much work in this space, and we still have high rates of maternal mortality, especially for women of color. And so in our last meeting with the group, that was where the group was leaning.
Okay. And I like that pick. Thank you.
Okay.
Yes, ma'am. Thank you. Madam
Thank
Chair.
you. Senator Mounts.
Thank you, Madam Chair. So under this new, I guess we'll call it like a framework, who makes the determinations of what's being accomplished and what's not being accomplished, or what's being accomplished or what is not being accomplished? Who determines that?
So the agreement is more prescriptive than it's always been prescriptive, but we were able to negotiate some of the terms. So for instance, under the last global budgets, 95% was negotiated in the agreement under global budget revenue. And under this agreement, we negotiated that down to 90%, because what we heard from the hospitals was that high-cost complex care was really, really expensive, and not all hospitals had the subject matter expertise to do that. So I'll refer to that as quaternary care. The other thing that we heard about was high-cost drugs and the impact on hospitals' budgets based on those high-cost drugs. So by reducing the amount that had to go into global budget, we've created some flexibility there on some of these high-cost cases. But the targets for savings, we've negotiated a much lower target than the prior negotiation, but we still have a savings target, but it's significantly lower than it was under the last negotiated agreement. We've also relaxed or removed the guardrails, so we have more time to reconcile the work as opposed to everything having to be in year. So the work and the guidance and the expectations are mostly from CMS and CMMI. I don't know if you want to add any more.
Yeah, I would just also add that so a lot of these measures, right, will be selected by the state, right? So we'll set the target. These are also not essentially triggering events for the termination of the model, right? So that's an important thing to note. The other thing I would say is probably the prime principal metric that we have to hit under the AHEAD model, same as in the total cost of care model, is the savings target for Medicare fee-for-service. That methodology is really carefully enumerated, so it's formulaic in nature, right? So the determination is not an arbitrary one. We've kind of very carefully constructed the formula to make sure that it's very predictable, we can calculate it, we can project it.
I don't know how this happens, but we have a rule. You're only allowed to ask one witness per panel a question.
Senator, this is a briefing. We're fine.
Okay, I apologize. But so if we have two very different systems in my district, in that we have Title Health and we have Shore Health, part of UMS. Of course, Shore Health, we have a significant project going on with the hub, or the recreation of the hub with the new regional hospital. So as this is progressing, if there is an issue, is that issue resolved through legislation, or is that issue resolved through the HSCRC or through the executive, through the Department of Health?
So I think it depends on what the issue is. So it's hard to say where it would land depending on what the issue is. So there are policies specific to HSCRC, there are policies specific to the Department of Health, and then there are certainly expectations related to the waiver agreement.
Yeah, but that specific project, right, there is a capital component of their global budget that's set by policy with the HSCRC. So if there's an issue, it would be for that component of it. It's financed through a bunch of different
I think I understand. Thank you.
Thank you, Senator. Senator Lamb.
Madam Chair. I was reading the AHEAD agreement, and I had a question about this provision in here that states if the state enacts legislation, implements regulation, or takes any other action that inhibits the ability of the state to participate in the model, and CMS determines that changes and or actions are not consistent with the agreement, with the requirements of this agreement, that could trigger, I guess, termination of this agreement. What legislative act would fall under this type of a category?
So in large part, that's a pull through the existing model. The types of risks that CMS is looking to mitigate there would be, for example, things that would add costs disproportionately to the Medicare Trust Fund, right? Things of that nature that wouldn't enable us to hit our savings targets, right? So I think they're fairly limited in nature, right? It'd be pretty clear if something was just going to formulaically disallow us to hit one of these targets. That's kind of traditionally how also how CMS has worked with us as we've talked through policy changes with them directly on kind of day-to-day basis as well.
Okay, that's helpful. So I guess just with regards to this provision, was there any prior discussion with the General Assembly members or leadership about AHEAD and this language specifically before it was signed?
So again, that language was not net new language. It was modified somewhat, but it was pulled through from the prior agreement. So on that particular language, no. I will just say, and I'll fall on the sword, we did some outreaches, but didn't do enough outreach on educating ahead. We were meeting with stakeholders the year before, and then we were told we'd get the agreement in the summer. We didn't get the agreement in the summer. We were told in August we'd get the agreement. We didn't get the agreement in August, and then we got the agreement in September. And we had always thought about getting a signed agreement with the team that knows the state of Maryland. And so even though we were meeting with stakeholders for a year plus, the federal government ate a lot of our clock to do what you're asking. So we did not do enough stakeholder outreach with the General Assembly.
But there was some anticipation that this was coming, right? So there was some awareness, I guess even over a year before now, prior.
We did do outreach when the NOFO came out, and we did meet with the General Assembly in March when we were applying for submitting our application, and we did discuss and share what was in our application. But again, we were waiting for the agreement, which is where the negotiations were happening. We were talking to hospitals the whole time, so we knew what we wanted to negotiate, but we needed a starting place where CMMI was coming from. And we didn't get that, unfortunately, until September.
Okay. When the state moved to a global budget model, the legislature wanted to help ensure that the model didn't impact access to care. And as a result of that, I think the legislature adopted statutory language that states that the HSCRC shall develop guidelines for the establishment of global budgets for each facility under Maryland's all-payer contract, including guidelines to prevent facilities from taking actions to meet a budget that the commission determines would have adverse consequences for recipients of services. Can you walk us through what are the guidelines for the development of global budgets?
So there are a number of, so those guidelines exist in a bunch of different places. I think the core guidelines that determine how a global budget is constructed is done in part through our annual update factor. This is the individual components that build up the adjustments to the fixed cost part of the revenue of a hospital. There's another component that's separate from that, or that's related, but governed by another set of adjustments due to volume, right? But I think, Senator, part of what you're getting at there is the work that is ahead of us, no pun intended, for the HSCRC is bringing more clarity around the access component of our work, right? So if you think about what the world looked like back in 2014, utilization was extremely high across the state. And so, you really could pretty clearly seek to drive down utilization across the entire state. We're now at a different point in our trajectory here, where we have to be cautious about where we're seeking further decreases in utilization, making sure that it's tracking toward low-value care, right, and things that are aligned with population need. So I think that is a lot of the work that now, at this point in the model, we're going to have to do as an HSCRC, right? And so that's a big component of this effort that we've just kind of kicked off in terms of understanding how should we be looking at access as we move into the AHEAD model.
So to follow up on that, I am concerned about the delineation between necessary and unnecessary utilization, that it's important to draw that distinction, that if I get unnecessary utilization, you want to reduce that, but you get to a point where you're reducing utilization that could detrimentally impact the care that's being offered and also, patients. I'm not sure that the model, I think, gets to the point of providing that level of assurance that we're not unnecessarily harming necessary utilization. And would be curious how you think you may be able to address that between now and July 1st, because, you know, there are a lot of milestones that are occurring on July 1st that we have to try to make, which is not too far. It's only 6 months away, I guess, right? So, you know, whether it's that or, you know, addressing things like age adjustment that I think are important for us to account for different hospitals at different populations that they're serving. The model, I think, doesn't fully account for age adjustment in those populations. There are other demographic differences that are not accounted for in the model. A lot of work over the next 6 months. Are those things that you're going to be able to accomplish in addressing in this model and for that milestone that we're looking at for July 1st?
So I'd say the milestone of the agreement does not necessarily hold us to doing all of those things by July 1st, right? Those are state policies, right? So we have discretion as a state to make those changes and evolve our global budget policies. I think many of the things that you're describing are very much on the radar screen in terms of internal state policy work that we're doing at the HSCRC. So, you know, the AHEAD model will allow us to have a risk-adjusted savings target. That's great. That then gives us the opportunity to, whereas we did not risk-adjust demographic growth in the current model, we can, you know, kind of develop a new policy, right, that would risk-adjust, right? You know, as a health services, you know, professional, I absolutely want to risk adjust everything, right? So I think we have the opportunity to do that. Some of the other items that you've mentioned, right? I think we have certainly some short-term priorities that will help us evolve our policies pretty rapidly. And then over the long term, what you described, identifying necessary and unnecessary care, but that's a very complex challenge, right? My sense is that we will make strides over the next year, but that will be something that will have to evolve over time. Currently in our models, right, we focus a lot on potentially avoidable utilization. I think there are many other ways that we can identify first low value care that's being delivered in a hospital and high value care that's being delivered in a hospital, but there are many other definitions as well that we'll have to look at over the
Okay, we
not
have
just
some
over
other
the next
questions
6
if we
months.
can, Senator Lamb. We'll come back to you. Senator Washington?
Thank you, Madam Chair. Nice to see you, Madam Secretary. Just a question. I'm new to healthcare and all the great work that you all do, but I'm really interested in what you all in the healthcare field. I wondered how does the HEAD model align with the work that's done locally? How have you made sure that those strategies or plans are working in tandem and not, you know, how do you make sure they're working in tandem with one another?
So that's certainly a focus of the model, and especially from community stakeholder. And you may have heard this phrasing, you know, that healthcare is local, right? And the needs of one community is not the needs of another community. So if you look at, let's say, Western Maryland, for example, their needs are going to look very different than, let's say, Baltimore City. Not only as you think about access to providers and people that choose to provide care in Western Maryland, but then you're traveling longer distances. So community stakeholder input is really, really important as we think about the model, and the governance structure for MCHE includes many more community voices than previously that was on that commission in particular. In addition, through other stakeholder engagements, there are multiple primary care stakeholder groups. That includes the voice of the local primary care provider to talk about what they're seeing, including their care managers and other people on their team. So we're getting that community feedback through a few different ways. Okay. Now, how does stakeholders are county governments, different entities, those different stakeholders, are they involved in this process as well? So we're including the
county health
local
departments?
Yep, the local health departments, the local behavioral health authority. In many other jurisdictions, if not all of them, they have local health improvement coalitions that also have that community voice. So we're bringing them all to the table in that diagram where you had the SHEP and the community platform. The community is really at the center and thinking about how best to meet their needs. The hospitals also do community health needs assessments, so they're bringing community health partners through that stakeholder, and we're certainly trying to align that work because we shouldn't have different lists for one community that they identified as their priorities needing for the healthcare delivery system to address.
Yeah, well, let me ask you one specific question about just the model and the work that you do at the department. There was a report that was done in 2024 with our former county executive, and a report came out stating that we have over 1,050 physician deficits in Prince George's. How does this model or any work that you're doing help drive down that deficit?
So you know, it will help in the investments that we're making in primary care. We want people to come to this state because their reimbursement is better than it is in other states. So by virtue of the fact that we have Maryland primary care, we've heard from lots of docs, if not for these additional investments into their practices, they might have had to have closed their door. We recently had dollars for over hitting the savings target that we were able to pull out in 2023 to make an investment in new primary care infrastructure, which we've done throughout the state. We use things like health professional shortage area as a way to attract physicians into areas where there's no primary care access. So we're trying to expand primary care access. I will also say that at least one hospital partner, Meritus, is opening up a medical school, and so they'll have their first class this August. The class won't be full, but it'll be their first year. I think they have projected 90 new students starting at their facility. So it's multi-pronged. How do we need more medical schools. We need to make reimbursement and payments more attractive that providers choose to practice in the state of Maryland. Administrative simplification, which I mentioned on one of the slides, many primary care providers said, you're asking so much of us, different measures for different payers, lots of demands. You have to make it simpler if we're going to be successful. And then loan repayment, and how do we help providers that are struggling with what they get reimbursed and, you know, outstanding loans. I will also say on a personal level, we want to make it attractive enough. I came to Maryland as a resident. I'm a native New Yorker, and I stayed. So how do we bring, as we open up more residency programs, people choose to be in Maryland, get integrated into their community, and then to choose to stay as providers? But we do have a lot of work to do, and we are working on a workforce strategy in general, just because, as I mentioned earlier, Maryland did not rebound as well as other states did post-COVID with their clinical workforce.
I'm not certain if there's other counties that have this type of deficit of 1,000 physicians in Prince George's. I appreciate what you said, but is that any way targeted to Prince George's County to help drive down this deficit that we have in the hospital, including the hospital beds? We have 475 hospital bed deficit as well. How does this all work together to make sure that we're driving down those deficits?
So I would say that the Huron report, which is the report that I think you're referring to, compared Prince George's to Prince George's and didn't look at it statewide. You know, I think there is opportunity and there needs to be some rebalancing, not just in Prince George's, but in other parts of the state. And again, as part of that workforce strategy, we have to look at all of it. For instance, based on some data we've looked at, we think we have enough primary care in Baltimore City, but they're not in the right places in Baltimore City. So in some parts of the city, we have too much, and in other, we really don't have good access. So we're looking at all of it.
Right. So you're able to give me an example about Baltimore City of how they're not in the right location. Can you give me an example about Prince George's County of
Prince
what
George's
strategy?
County is understaffed. Is understaffed, and so again, bringing more residencies. Under the Equip Primary Care Program, we will be bringing new primary care practices to the county, and we're looking at, again, additional enhanced payments overall by increased primary care investments under AHEAD to create incentives for people to want to practice in Prince George's County.
And you'll have those incentives ready for us to be able to review, and do you have a list of those that we can see?
We have a list of the 11 sites, yes.
Okay.
So we can provide those, and several were in Prince George's
Senator,
County.
can you
They
take the
were-
rest of this offline since it's
absolutely.
just for
Yep,
your county?
absolutely.
I
Yep.
appreciate it. Senator Reedy?
Thank you, Madam Chair. Just a question. I was actually here when we passed the first model. I was 12 at the time, but I think we probably spent some time together in committee. Can you just advise, is the is the onus in this new or this adjusted new model, is the onus going to be still where it is on the hospitals, or are we going to be putting, are payers and provider, I mean, is there going to be a more shared, I don't know if risk is the right word, but more shared responsibility, or is it kind of still the same? The hospitals feel like it's kind of all on them, and I know that's not the intention, but can you, I hope my question makes sense. Are we balancing it a little bit more, or is it still going to kind of fall pretty heavily on the hospitals? Not that they shouldn't be responsible, but I'm just trying to understand.
So I can certainly start. So I think the hospital components of this model are largely, kind of pull through, right? So the global budget mechanisms, et cetera, right? I think what this allows us to do is find other ways to coordinate and bring other stakeholders into the accomplishment of statewide goals, right? So the original model was very hospital-centric in its goals, right? So as we broaden out, I think it's it's going to be incumbent on us as a state to identify opportunities for, hey, as we look at a more coordinated statewide population health strategy, who else needs to be at that table, right? And contributing.
But the model itself doesn't really do anything more than it's still a hospital model, correct? I mean,
I think I would characterize it as the required kind of tent poles of the model. So a state wanting to join this national model, you would have to have a pretty robust hospital global budget policy. You'd have to have a set of policies around primary care, right? And then I'd say more modest requirements around behavioral health investment, right? So I think those are kind of the tent poles, right? What it does do, though, is also requires the state to take some steps around setting these, kind of statewide targets.
and last question, thank you, Madam Chair. Last question, it's kind of tied into this is, and I represent 2 counties, both have 1 hospital each. And I know in the rural areas of the state, there's been challenges sometimes with getting capital investment for their hospitals. In Carroll, for example, trying to expand some services, and we've gotten some capital investment, but it's challenging. So kind of is the idea of the more we put on the hospitals to achieve this, or is there going to be a component to that where HSCRC or the health department are looking at advocating for the appropriate capital expansions when needed or when necessary? Is that any part of your all's process? I know it's not probably normally, so I'm just curious.
Yeah. So within the HSCRC work to review our policies, I think one of the things that's going to be on the table, and it's a matter of prioritizing, will be our kind of capital funding policy. So the policy mechanism by which a hospital can kind of propose a project for which they have a CON. What are the circumstances? How much of that should be financed through rates versus other mechanisms? That will certainly be on the table. What I would say, though, is that I think the challenges facing rural hospitals and recapitalization are national in nature, right? They are certainly national in nature. I think what we've seen over the last few years, and Senator Motz's example of what Easton has been able to do, is it provides us some flexibility to finance those projects in some different ways. We have to continue to work and evolve that, but we have that opportunity under the current model. We will continue to have that under the
Okay, thank you.
Vice Chair Hayes.
Thank you, Madam Chair, and welcome, Madam Secretary and Director Crum. To piggyback on the capital question, there's no secret that this session the theme is all about the budget, right? And even the governor says that Maryland's economy is lagging behind other states. I guess my question is, what does the HSRC, I always get the acronym wrong, so I'm gonna try this. HSCRC, yes, and MDH due to compare Maryland investment and innovation in healthcare to other states. Is there a comparison or analysis done to look at what investments other states are doing?
So we do some benchmark comparisons in terms, less in terms of capital investment or and investment in things that we don't kind of directly regulate, right? So in other words, we don't require hospitals to make certain investments, right? What we do benchmark is, for example, inflationary costs nationally for various regions, like counties, et cetera, right? We do a lot of that benchmarking to establish how much of a hospital's revenue in Maryland should be inflated and what components of that should be inflated on an annual basis, right? So we do a lot of that benchmarking, but again, historically, we have not, HSCRC has not directed those investments in a very kind of tight way because, you know, hospitals need a lot of kind of operational discretion, right, to run their business.
I guess to that point, like, so hospitals are often the largest employer. Like in my district alone, is home to, if the district proper doesn't have, is at least 4 districts circling my district, and so typically they're the largest driver of the local economy in many cases. So have we evaluated the possibility that constrained Maryland hospital growth can negatively have an impact on Maryland's economy? Has there been any analysis to that effect?
I mean, I think what we've looked at quite a bit is how has hospital cost growth, so not just kind of revenue growth, but rate impact, right? How is that tracked relative to gross state product, right? So in other words, are we ensuring that cost growth is not kind of outstripping other parts of the economy? That's largely how we've, the analysis that we've done. I think, we could certainly look at other economic analyses, but that's kind of principally what we've looked at.
And if I could add to that, by virtue of all the things that we do in the state of Maryland, we are leading states in healthcare outcomes, and healthcare access. We have one of the lowest uninsured rates in the country. Or let me just say, that was predetermination. It was redeaths. It was about 3%. It's probably a little bit higher at this point. But we are ahead compared to other states. And there's an economic value to that because people are able to go to work, be present for their jobs because their health care and their chronic conditions are well managed. So it's something we can start looking at, such as absenteeism and presenteeism in the workforce. But we certainly have a healthier population compared to other states. I think depending on which ranking you use, we're anywhere from 8 to, we're usually top 15 and sometimes in the top 10.
Thank you for your responses. Thank you, Madam Chair.
I have a couple of questions, and we're going to have a briefing just a little later on the ED wait times. But apparently, at least what I hear, one of the issues is it's about capacity. We have fewer hospital beds now than we had in 2014, and our ED wait times are the longest in the country. So how does the AHEAD model help us to grow the beds and maybe shorten ED wait times because we have beds then for the patients? What's this going to do for our ED wait times?
So I think a couple things. By comparison, right, back in 2014, we had extremely high utilization, so therefore too many beds, right, in total in Maryland. I think where we are now is we're in a different place. Utilization, though, is still high in some parts of the state, probably low in other parts of the state. So I think what the work that we have ahead of us is really to assess on a more of a regional basis, where are we underclubbed in terms of capacity, And the other thing I would describe is capacity really is more than just the physical location of beds, right? It is the staffing, right? So we have to understand what is staffed and what's not staffed. And it's also how productive is that bed, right? So in other words, is that hospital, kind of at an appropriate level of length of stay, right? So, are you using that bed for the number of cases that you would expect? So all of that work, I think, is we'll discuss that more in the ED Wait Times Commission work. But all of that work, I think, is going to be critical to understanding, hey, where are we underclubbed in terms of physical capacity? There are certainly hospitals that would need to grow in that regard. Where are we underclubbed in terms of staffing? I think the Secretary mentioned a number of workforce challenges that we're facing. I mentioned the physician cost concern. That is also creating a staffing challenge. And then third, where are we at excess length of stay and other metrics of essentially productivity, where we really need to incentivize hospitals to focus on that.
So, I'm aware of all those things. I worked on the ED Wait Time Commission for over a year, worked on the workforce staffing. But I continually get calls from people that have waited 8, 10, 12 hours in the emergency rooms in my county. And so it's nice to talk about this, but we really need to find some way to alleviate the problem that the hospitals have. And I'm not sure, listening to the HEAD model, that the financial issues are going to, I still feel there's financial instability. How can hospitals grow, their capital budgets when they're struggling? And so, it just all adds up to not enough beds, not enough staffing, not enough money, and long wait times. So it's just a lot. I think Senator Lamb has one more question.
Yeah, so just to kind of follow up on the public health trust piece, I think these are funds that are being taken out, and I know it was approved by the HSCRC, I think last month, that are being essentially taken out of the hospitals and included in this trust, which from a public health standpoint is great, support, additional public health measures. But how are you going to ensure that it's linked back to something related to hospitals? Because doesn't money come from the hospitals, making sure that it helps them with care coordination, other programs that might actually support that work? And is there going to be a bill on this? And can we see any provisions on this bill? We're already, almost 2 weeks into session. Can we expect a bill on this? And is there something we can see about what that structure will look like?
So there is a bill on the Population Health Trust, but it's just to establish the special fund. It has no details other than establish the fund just to have a place to park the money. As I mentioned, we're in the process of developing the criteria for the Population Health Trust, but it has not been vetted with our hospital partners and other partners on how that money gets spent. But I'll give you a perfect example just based on what the chair just said. So we know that ED throughput is one of the issues that's backing up our emergency rooms. We have people sitting in beds that are waiting to be discharged, and then we have people sitting in the ED waiting to go to the floor for a bed. We don't have a good post-acute care solution in the state of Maryland, which is what then backs up the beds. So you could imagine potentially using this Population Health Trust to develop a subacute or a post-acute value-based payment arrangement. How can we incent our nursing homes to be better partners to accept those discharges so we could create hospital capacity in the hospital and then move the patients that are sitting in the ED into the med-surg bed that they're waiting for? That's just one example of a way that trust could be used, supports the hospital, helps with throughput, and arguably creates a return on investment by virtue of the fact that your length of stay is going towards normal or well-managed national trends than what we see today.
Okay.
And to clarify, that $25 million did not come out of hospital operating budgets. It was an add to rates. So it's not money that's already sitting.
So it's a tax on hospitals?
No. It comes out
added
of
to their
payers.
rates, though?
Payers.
Oh, tax on payers.
It's an addition to the rates that payers pay. Yeah.
The insurance companies? Mm-hmm. Gotcha. Okay. would suggest that you look at and contact maybe our colleague Senator Washington, who helped establish the Health Equity Commission, because she has had some, I guess, heartburn about how the commission has changed completely in the direction that she, as the Senate sponsor, had originally envisioned this. Obviously, there were a lot of changes being put in to the commission through HB 1333 last year. Just, a lot of things that I think may be worthwhile reaching out to her about. I do want to.
Can I just add to that? So
Yeah.
what wasn't on the slide is we recognize that those requirements of the original Maryland Commission on Health Equity are still there. So that's specific to the health department. That's not specific to AHEAD. The health department is still working on those initiatives. We have a data dashboard that we've been vetting by some of the General Assembly members that have interest in that. Is this what you meant when you wrote it in the law? So that work continues, but that's MDH specific.
Okay, it may be helpful to reach
Sure,
out to her to
sure.
talk about that,
Yep.
just because I think she has a lot of angst about the direction. But you've also changed the composition of the committee members a lot that alters, that commission's ability to kind of work on those issues that they were originally charged with.
I will
do
also
want
say
to.
those other members often didn't show up or sent very junior staff to the commission meeting. So part of the list came from attendance from prior meetings and who was engaged in the process on the Maryland Commission on Health Equity.
Okay, well, she's thinking about a bill, so you may want to connect with her. I do want to touch on the chair's kind of point, because there's some dissonance here with, I think the chair was mentioning a concern about there being not enough hospital beds. It's an issue that I've heard from folks who lead hospitals as well. There just aren't enough beds here in the state, and it's causing a backup, and also with the ED wait time issue. But you just said that there is not an issue with not enough beds, that you think we have too many beds. So how do you square that circle there?
What I'm saying is that you really have to look at a hospital by hospital, region by region approach. So you cannot say across the entire state of Maryland, right, do we have too many beds or too few beds? You got to look at the kind of regional needs. So I'll give you an example. In a part of the state where you might have kind of multiple hospitals serving that region, not all of them are serving patients who come from that county, right? The patients kind of migrate across county lines, right? So you got to look at those puts and takes. You got to look at what types of beds are within the hospital. You got to look at how is the hospital able to manage those beds in terms of staffing, et cetera. So all I'm saying is that it is a kind of multifactorial kind of problem that we have to look at. And, I think we are in process of developing kind of a better access framework to be able to look at that and understand better where are we underclubbed in terms of bed capacity, right? And what's the root cause of it? Is it, bed type? Is it bed total number of beds? Is it length of stay, et cetera?
Okay, so we'd be interested in the future to hear about how you're incorporating. Sounds like maybe some of the beds aren't in the right place. Some of the types of beds aren't the right beds that you need in certain locations. If the model is going to try to incentivize or make adjustments so that hospitals are able to get those, health systems are able to get those beds in the right place, would be curious to hear about that in the future. And then if you can send us the old agreement, you referenced the fact that the provisions in there that pertain to the legislature in the current AHEAD agreement were pulled through from the prior agreement. If we can, because I'm getting some mixed messages here and would like to see the old agreement to see how that language was pulled
And they
through.
were for sure modified, right? Then the language is different, right? But the intent is similar, right? So we'll send that to you and I'm happy to offline
Okay,
on.
yeah, if you can send us the old agreement. Thanks.
Thank you, Senator. I think that ends this part of the AHEAD model. Now we're going to bring up the Hospital Association, and we have a PowerPoint from them. I think. Well, Welcome, Madam President. It's nice to see you at the table.
Good afternoon, Madam Chair Vital, Vice Chair Hayes, and members of the Senate Finance Committee. It's exciting to be here on this side of the table and to have an opportunity. I told them that the room looks so much bigger sitting up there than it did back here, but it's a pleasure to be here, and it's been over a year since I was in this room and had the opportunity to interact with some of you, and I've seen some of you over the interim. I'm going to make my comments very brief because I have some very dynamic subject matter experts here at the table with me. I just thought I'd share very quickly that since we were last together in my previous role, I've spent the year getting to know Maryland's hospitals, and I know a few of our hospital association members are represented in the room. Spent a lot of time getting to know stakeholders and spent a lot of time meeting with the Secretary and Dr. Crum talking about the AHEAD model and learning about how it's impacting, how its implementation can impact the state. I did want to speak, Senator Guile, to your question, let you know that we have been talking with the Secretary about new members for the MCHE that represent the hospital field. We're really trying to make sure that we understand the jurisdiction of that commission and what their responsibilities are so that we can identify the appropriate hospital representatives to join that work. But you're absolutely right. It is a larger group. Senator Lamb pointed out the composition has changed, and we want to make sure that we have the right voices at the table on behalf of the hospital field. So certainly in our continued conversations with them, and we're talking very regularly, we hope to get that locked down very soon. So I just wanted to close the loop on that. With that, Madam Chair and committee, with your permission, I'll turn it over to someone that you have all heard from before and just say it's been my pleasure. You understand the importance of teamwork and the team that you have in this committee. I've had the honor of working with an incredible team at the Hospital Association. You'll hear from some of them on this issue and some on the ED wait times issue. So thank you very much.
Thank you very much. Patrick, are you going to go next?
I am next. So Chair Beidel, Vice Chair Hayes, distinguished members of the Finance Committee, Senate Finance Committee. Really great to be back with you all today. I really feel at home in this room, and I miss you all. I just want to provide some remarks that just give a little feedback on the AHEAD model from the Hospital Association's perspective. And really, just to start off, this is our mission. Our mission really is to serve Maryland's hospitals and health systems through collective action to shape policies, practices, financing, and performance. And this is really critical to advance healthcare and the health of all Marylanders. That is at the essence of our mission. I think that this is really a consequential sort of inflection point for Maryland healthcare with the changeover to the AHEAD model. And it is of great interest to our members. We've got 60 members, and at our essence, the mission is really healthy hospitals, healthy communities. And so, we're really committed to the aims of the AHEAD model to enhance health equity, population health, and really to lean into primary care investment. Just you all know this, you have hospitals that are serving your communities every day, but in 1 year, hospitals care for more than 5 million people, whether this is through inpatient care, the emergency department, or outpatient services. And, we have tremendous community benefit investment that we provide each year. We really have our hospitals serving as the backbone of our economy with over 223,000 jobs, individuals directly and indirectly employed by our hospitals. And we're caring for Maryland's most vulnerable, expending $2.2 million daily on care for the uninsured and underinsured. And our hospitals are really proud of this, really do serve as a national model for healthcare. This has been a big part of the Maryland model. Our hospitals have been driving innovation under this unique model. Under our fixed budget system, our hospitals in our state have saved over $4.6 billion for Medicare. And this is a real accomplishment to the hard work that we've put in, high quality, efficient care delivery. We've done this while maintaining top tier, cutting edge medical care. And our hospitals have reduced disparities in unplanned readmissions, preventable admissions, and timely follow-up care by race, and also for areas that experience challenging socioeconomic conditions. So we're really proud of that. You know, the HEAD model builds on this legacy with an even greater focus on equity and population health and creates new opportunities for health of Marylanders. We have hospitals that are set up all throughout the state to provide this innovative care. And really, what are we doing? You know, for acute care, we're providing life-saving interventions for emergencies, delivering high-quality care for acute illnesses, managing complex conditions using advanced technology and specialized expertise, and then ensuring smooth transitions to post-acute or rehabilitation care for recovery. We're also really providing a lot of community wellness and prevention in our communities, promoting healthy lifestyles through campaigns on nutrition, providing screenings and early detection for cancer, addressing social determinants of health, partnering with organizations to support underserved and at-risk populations, and leading vaccination drives and public health initiatives. And so as we head into the HEAD model next year, we really do have an opportunity to build on this important work that's been underway. The HEAD model does create new opportunities to develop partnerships and share accountability across the healthcare spectrum and reinforce the importance of population health and health equity. Our hospitals, to improve population health, will play a critical role in leading local interventions and focusing on identifying populations that are most at risk for poor outcomes and developing targeted interventions that improve health. For health equity, each hospital will create health equity plans in alignment with the state's health equity plan to demonstrate how health equity is actively incorporated in hospital operations strategies and services. And then partnerships. Our hospitals are going to partner across the care spectrum to improve care coordination and ensure patients get care at the right time and in the right setting. So as we head into the HEAD model, what do we need to do to achieve success under this model, this new chapter? We are at an important time of transition, and our hospitals really need to be assured that they're going to have a sustainable future. I think that is really something that is at the center of this transition year. The HEAD model aims to strengthen primary care through increased investment and resources, and rightly so. Primary care is limited in certain communities, but it will take time to realize the promise of care transformation through expanded access to primary care, and our hospitals will continue to be a critical safety net for Marylanders, providing 24/7, 365 care for acute and complex health needs for our communities with limited resources and for patient needs that are above and beyond primary care services. Our hospitals must be sustainable to provide Marylanders with the full spectrum of essential care services. Our hospitals need HEAD model policies that ensure that they are prepared to provide this access that communities rely on. Hospital sustainability requires sufficient resources to support the needs of our growing and aging population, facility capacity and modernization, and efforts to recruit and retain a skilled healthcare workforce. Our population is growing, aging, and becoming more complex with multiple chronic conditions. By 2030, the percentage of our population aged 65 and older is projected to grow to nearly 20%. And naturally, the demand for healthcare will increase. Hospitals must be equipped to handle these changing healthcare needs. And unfortunately, we are also confronting an increased burden of chronic disease and higher spending due to chronic disease. The number of Americans with 3 or more chronic conditions is projected to increase substantially by 2030. Heart disease costs increase significantly, and in Maryland, the percentage of our population with prediabetes is projected to reach nearly 30%, and the percentage with diabetes will reach more than 15%. Figures are even higher for seniors, with 51% having prediabetes and 26% with diabetes. So the HEAD model creates opportunities to revisit policies to support hospital modernization and to ensure that healthcare infrastructure keeps pace with evolving needs. We need to ensure that hospitals have resources to address routine upkeep of hospital facilities to ensure safe, functional, and efficient care settings. our hospitals also have to have the ability to improve and expand their facilities to increase capacity and accommodate the growing demand for acute and complex care services, safeguarding quality care for all patients. Hospital sustainability depends on having skilled physicians, nurses, and staff. Staffing has been a challenge, really starting with the pandemic and continuing on into these post-pandemic years. Labor costs have grown by 19% since 2019, and the rising cost of healthcare staff must be addressed to prevent shortages and maintain care quality. And funding policies, HSCRC funding policies, must support hospitals' ability to attract and retain these critical staff members. So ultimately, the AHEAD model provides Maryland with an opportunity to further deliver on the promise of healthy communities and healthy hospitals. We can improve care delivery and outcomes through population health and health equity initiatives and partnerships across the healthcare spectrum. And at the same time, we can have policies to ensure that hospitals are resourced to support the growing and increasingly complex patient population, modernize our facilities and address routine maintenance needs in buildings and ensure capacity, and also to recruit and retain essential physicians, nurses, and other hospital staff. I mean, I think what we really have been hearing today is that our hospitals have been in an environment in which they really have been resource constrained. It's been a challenging operational environment for our hospitals in these post-COVID years. A number of them have experienced negative operating margins in this period of time. And so for us to be entering into this AHEAD model, our hospitals really need to be shored up to ensure that they are able to provide the acute care needs that they have to provide as a core part of their baseline mission. And that's going to require HSCRC policies that really are sufficiently resourced with their funding to address these needs, these deferred capital needs, these staffing needs, and the demographic growth that we're going to experience. And so that is really, I think, a high-level message that we want to communicate, is that we really see the promise and the opportunity of the model. We got to make sure that our hospitals are in a position to be successful.
Yeah. Thank you, Patrick. Good afternoon. I'm Tori Bayless, and I serve as the CEO for Luminous Health, and I also serve as the Vice Chair of the Board for the Maryland Hospital Association. Madam Chair, thank you for the opportunity to talk about this pretty important topic. I could say ditto to everything that Patrick said, but I wanted to also provide perhaps just a little bit more context. And again, while the AHEAD model has a lot of promise, I think what we've learned 10 years into global budgets and 5 years into total cost of care is that some elements of the policies need to be revisited, corrected, and updated before we can proceed with the AHEAD model. So I'll give you a little bit of an example here. So some context, just down the road, Anne Arundel Medical Center, part of Luminous Health, this morning has 435 patients in it. It has 35 patients we have boarded in the ER awaiting beds, as you heard, having those throughput issues. Some patients have been in the ER for more than 2 days awaiting beds. And the hospital's actually licensed to have about 370 patients. So we're at 55 patients over the number that we're set for in terms of our license and our physical layout. We've seen a 14% increase in our ED visits over the past 2 years. You might say, well, why? Why so much? And I would say a couple of things. There's patient choice, there's quality and reputation, there's EMS preference, there is payer preference, and there's population growth, aging, and higher acuity that we're facing. So again, as we think 10 years into the model, I think there are some unintended consequences of the model, and I just think we have to, a moment of caution before we proceed with the AHEAD model, some things that just need to be addressed and updated, if you will, before we can say for the whole field that we're very comfortable with where we're going. I think you can agree with a philosophy, but tactically what the hospitals are facing is pretty significant financial instability. So I would say that this need for stability that Patrick referenced, I certainly echo that. Stability has been a hallmark of the system, the all-payer system that we've had in Maryland for 50 years, but it's not feeling very stable right now. So if we look at some of the acute care hospitals, 19 out of 42 are losing money right now, and that's based on HSCRC data that doesn't include a number of expenses that aren't funded through the model, such as physician expenses. That's not stability. And, a few years back, that would have been essentially calamitous, where alarms would be sounding and the like to say this is not okay, given how much we serve as the infrastructure for population health. You've had several excellent questions already of the Secretary and of Dr. Crum. I would just share a couple of other comments to provide some additional context. The operating margins are definitely compressed. To run 24/7 operations, we have expenses that are not funded through the model. A lot of these, for example, are physician expenses. I think if you or I or any members of our family present to a hospital in your jurisdiction or anywhere in the state, you would expect there to be an ER physician there, a surgeon available, an anesthesiologist, be able to get the care that you need 24/7. Those costs of the physicians staffing the hospitals 24/7 are not included in the model. And I think Dr. Crum and I would certainly agree, he called out this extreme increase in labor expenses. The extreme increase in labor, not counting physicians for Luminous Health, is actually much higher than what Patrick demonstrated collectively for the state. But as an example, over the past 6 years, we've had a 38% increase in our labor expenses. 38%. So if you like to study CAGRs and things like that, compound annual growth rates, at 6.3% a year. That's at a time when the rate increases coming through the commission were about 3.4%. That's not a sustainable model. Well, why are our costs so much higher than perhaps the average of the state? Because our hospitals are growing. That's, grow can't be a 4-letter word under the model. And some of that is really just reflective of the demographics. So then if you layer in what Dr. Crum referenced, the physician expenses, it's twice as fast a growth rate. The cost to staff the hospitals with physicians across all the specialties and what our communities expect and certainly what they deserve. We talked about the demographics a little bit. We have seen this, tsunami, the aging of the boomers. The youngest boomer turned 60 last year. We've had a 40% increase in the population over age 65. As much as we want to focus on prevention and primary care and population health, people are living with these multiple chronic illnesses, and it really is going to drive up demand for acute care hospital services. We do need stronger capital investments as well. This has been an area of concern collectively across the state of Maryland. Maryland hospitals' average age of plant, for the accountants in the room, is higher than the nation. And at Luminous Health, ours is actually the highest in the state. That might surprise some people. So under the model, over the past 5 years, there's been what we call significant excess savings. We have a target that we have to meet against the Medicare, the contract with CMS. We have exceeded the savings target for Medicare fee-for-service by over $1 billion. And I'm concerned that some of the way we're exceeding that is by rate suppression to the hospitals. If it was all coming through reduced utilization and better care and better clinical outcomes, but if it's through rate suppression to the point that hospitals are operating in the red, that's really not sustainable. There's a whole body of work too we could talk about outside of Medicare fee-for-service on payer accountability. Denials in the state are up threefold, and to be able to save money under an all-payer system by denying payment for medically necessary care provided in the hospitals, that's not going to work either long-term. So we appreciate the attention of this committee. We appreciate the attention through the legislature, as well as through partnering with the Department of Health, the HSCRC, as well as the Maryland Insurance Administration to address these issues. They are complex, but the math is not adding up. And as enthusiastic as we are about the principles of the AHEAD model, we do need really urgent action around some of these policies that have not been addressed. I was glad to hear Dr. Crum and Secretary Herrera-Scott's attention to these items. But we have to address them quickly because we're in this 11-month window before AHEAD is live. And we were concerned that several of these issues have been raised and have not yet gotten the attention that they need. So thank you for the opportunity to share some local experience.
Again, thank you for this opportunity, Madam Chair. My name is
minute.
Tequila.
You can pull that closer.
Okay.
Lots of.
I'm new to this side of it.
Again, thank you, Madam Chair, for the opportunity to be here. My name is Tequila Terry, and I'm the Senior Vice President for Care Transformation and Finance at the Maryland Hospital Association. And really, I just want to sort of underscore what my colleagues have just articulated and just emphasize that the ability to address the areas that we're describing in our presentation today are really within Maryland's control. Before we move to the AHEAD model, some of the solutions may be regulatory in nature. Some may require legislative remedy, but working together with the HSCRC, with the Maryland Department of Health, the Maryland Insurance Administration, really we want to be able to ensure that these issues are elevated in their understanding and the urgency is conveyed. We really have an opportunity to act now to ensure that Maryland has both healthy hospitals and healthy communities as we begin this transition to the AHEAD model.
Thank you, Madam Chair. That concludes our presentation, and we thank you all for your interest. I think there are some questions for us.
I think Tequila gets the award for the shortest presentation today. Thank you. Senator Kramer, I saw your light first.
Thank you, Madam Chair. So I believe you all were in the room when we had the department up, and I made an inquiry about, well, what are the costs associated with implementation of AHEAD? And unless I misinterpreted that, it sounded like, oh, no fuss, no muss, there's no changes, there's no costs, don't worry about it. And now I am hearing, again, unless I'm mistaken, a very different sentiment about the financial resources, the problems that are facing our hospitals. And going forward with this model, it sounds like there are going to have to be answers to, I believe it was Patrick who said, resource constrained being a huge issue, and then this concern that maybe what's happened is rate suppression, and all this ties into the HSCRC. So would you all please share with the committee your impression about, is in fact all this going to be cost neutral, or are there going to be costs borne by the hospitals that then I'm assuming need to be addressed in the rates so that our hospitals are in a position to fulfill the goals of AHEAD? Would you mind addressing that? And whomever it is that you deem is appropriate, I'd be fine with. Thank you.
Yeah, I mean, I think at the heart of our funding system for hospitals, we have global budgets, and our global budgets need to be set sufficiently to account for all these costs that we've been talking about, the expected increased costs to care for a growing, aging, complex population, all these inflationary cost pressures that we've been seeing. And it is a fact that in the years that we've been under since COVID, hospitals have been underfunded for inflation, and the HSCRC took some action last year to work to catch up on some of that. But more work may need to be done there to make sure that our budgets are keeping up with the cost pressures that we have. The third thing is the staffing costs. You heard that the staffing costs have really been a challenge. And this is happening at a time when we still have significant vacancies for health occupations in hospitals. So how are we going to keep the people we have? How are we going to recruit the people we need? And how are we going to ensure that we have physicians who are providing essential services in our hospitals when those costs are really becoming an increasing and growing challenge? And
so Patrick, is there a disconnect with the HSCRC Because I am hearing these concerns. I'm trying to figure out where is the pressure relief valve that's going to afford our hospitals to be fulfilling the desires of what AHEAD represents and the ability to not only survive but thrive. So is there a disconnect there? Give me some idea so that I better understand.
Yeah, I mean, I really do hope that there isn't a disconnect. I think that the global budget, structure that we have does offer a lot of promise. It provides some real stability for hospitals. It really helped hospitals during COVID. These are structures that continue into the new model, but so these are in some ways this is in some ways a carryover element to from the old total cost of care model to the new model. But we have to make sure that this element, which is part of the AHEAD model, is working, for our hospitals and all the tools that we have to ensure that hospitals are resourced, are being deployed to keep up with these costs. And so I think what we're hearing is good focus on all the ways that the AHEAD model is leaning into some of these innovative care transformation initiatives, building out population health, leaning into improving health equity, really having a primary care strategy. Let's do that, but let's take care, of some of these core funding structures that we have in the existing model at the same time. I think that's what we want to make sure that we're doing. Let's do both.
And what's the answer if we don't get there? Is there a legislative response? What is the fallback if you're not getting there?
So again, we have to move forward with a parallel strategy. That is what our ask is. Our hospitals are very much in support and favor of engaging in population health interventions. Everyone supports the expansion of primary care. It's critical to our state, critical to the people around, all of the counties in Maryland. In parallel with that, though, we have to be rooted in reality of what's happening on the ground today, which is people still need acute care services. People rely on hospitals, so we need to make sure that hospitals are resourced to support the populations that continue to go in because there's been a car crash, because there's been an injury, because someone's had a heart attack. These services that happen every day of the week, we need to make sure that we have capacity to support those issues while we also build towards the future, which is that vision that the AHEAD model creates. And so that is what our ask is when we talk about how do we move forward? How do we build a dual strategy, a parallel approach so that we are preserving resources across the healthcare spectrum, acute care services, as well as primary care and other services that Marylanders need.
So it takes money.
Senator, if I could be a little
Chair.
bit more concrete on the issue, just if the policies that we're enumerating are not adequately addressed, and it's not a one-size-fits-all, the hospitals really serve as the conveners under the model because the authority of the Rate Setting Commission is limited to hospital rates. So they're trying to create structures and incentives for us to invest appropriately in the health of the populations we're serving. That's the intent, of course. If hospitals don't have a margin, we can't make the population health investments in the communities. We can't structure the partnerships. We can't. So there's an inequity in the margins that we're seeing across the hospitals based on some of what Dr. Crum referred to as the unique, what's going on in each community, in each hospital, what's going on with the economics of those hospitals individually. So if you don't have the margin, you cannot make the investment in the population health issues. I would love to make a whole lot more investment, and the risk is that it could ultimately limit access. So if you've got services that are loss leaders, if you will, services that are not well funded, services that you're losing money on, you start to say, can I keep doing this? And that's not what anyone wants to say to the community that they're serving. So it really is this structure of getting the global budgets to be at a place that reflect the volume of care, the number of patients served, and the complexity of the patients we're caring for, while providing margin. All the hospitals in Maryland are not-for-profit. That doesn't mean that we don't need to have a margin. That margin is what we use to reinvest in the facilities that we have, in the clinical programs, in population health. Without a margin, you cannot advance what we're all trying to accomplish under the AHEAD model.
Thank you. Thank you, Senator, and Senator Ellis.
Thank you, Madam Chair. Thank you for your presentation. Going through, looking at page 6, Patrick, of the slide, a track record of success, and you talked about a $4.6 billion Medicare savings. So my brain was working, and Medicare, that's federal program, state doesn't have a match, all federal, which cares for elderly and disabled workers. So I was thinking, what's in it for our hospitals to just squeeze all that savings out of a federal program? And we cry about the hospitals not having enough resources. And President Bayless, you touched on that for a bit, and I'm curious, why would we do that if it hurts the bottom line, the margin? And when you squeeze those savings out, I'm thinking you squeeze out service for seniors.
Well, you're potentially squeezing out margin, and so I mentioned a $1.1 billion in excess savings. So the agreement with the federal government says you have to save this much each year for Medicare fee-for-service. And we have not only saved that, we have exceeded those savings by $1.1 billion over 5 years of total cost of care. To your point, Senator, we don't get extra credit for beating the model, beating the target. So that's my concern about rate suppression.
Why do we? Why do the hospitals beat the target? Yeah. Why you go above and beyond?
I think that might be a question for our colleagues at the Health Services Cost Review Commission, because they are the ones that control the rate setting that ultimately generates those savings. And so they're doing their best to hit the targets, but they ultimately have to manage that balance of making sure that the hospitals have funding and resources while also hitting the targets that are agreed to with the federal government. So I think that would be a question for them.
Yes, thank you. So I'm not talking about hitting the target. I'm talking about going up.
Agreed.
Above and beyond, or below or lower. You know, I mean, it's just not really clear. I mean, I think President Bayless has the answer. She was motioning when you were speaking, and she was thinking, am I allowed to say this? But yes, you are. You're allowed to say it.
Yeah.
President Bayless, you were saying why?
I've said it. I think it's perhaps an abundance of caution by the regulator to meet the target. We've held back rates, and we've underfunded inflation, and we've underfunded the labor, and we've underfunded the demographics, and we've underfunded the aging population. So all of that results in excess savings, which isn't necessarily something to be super proud of if it puts the hospitals into operating margin into the red.
But these are smart people that serve on these. So why would they do that? I'm still, you can tell me offline, but I'm just curious to know why that would happen. Thank you, Madam Chair.
Senator, I had the same question. I'm like, where's the $1.1 billion savings? Do you get a reward for that? No? It's my understanding that a hospital that sees fewer patients gets more reward than a hospital that has a larger population. I can't understand that at all. Somebody want to tell me a little bit more about that?
Yeah, Madam Chair, the way that this works is that Maryland has entered into an agreement with the Centers for Medicare and Medicaid Services, their innovation center. And that agreement requires the state to achieve certain targets. One of those targets is for generating savings to the Medicare program. And so the state has written into its agreement each year how much that savings is supposed to be. The HSCRC team does their work to identify what the spending in Maryland will be, to anticipate what the national trends will be. And they do their best to actually try to project out how much revenue should be constrained in hospitals in order to hit those targets. But what's happened over the last few years is that the amount of savings has been generated well in excess of the targets, so almost double of what the federal government has asked for. And so that is what's contributing and really at the root of the issue that the hospitals are describing is this tension between generating savings for the Medicare program, as we are obligated to do, and really want to do as part of our agreement with the federal government, but doing it in a way that doesn't balance the needs of the hospitals and their ability to provide care to communities around the state. So it's really this idea of, the balance that's needed across, meeting our obligation and ensuring that hospitals have enough resources. And right now, things are out of balance is the way that I would describe it. We have too much going into savings and not enough actually being resourced to the hospitals. So that is what is at the root of the issue.
Thank you. Senator Lamb.
All right, thank you. And I think the chair teed up what I was going to touch on as well, which is, I think Ms. Bayless and many of you kind of point to the fact that it's a really challenging situation circumstance right now. I mean, you point to the fact that 19 out of 42 hospitals are losing money. These cost savings of $1.1 billion that are generated, just to be clear, these are cost savings to CMS, to Medicare. That's actually belt tightening for the hospitals, right? So these are dollars that are coming out of hospitals that are savings going to CMS, to the federal Medicare program. At the same time, I think in the governor's proposed budget, there's an increase of a $50 million assessment on hospitals this year, right? And there's a bill to deal with a sunset provision that also adds and makes permanent an assessment on hospitals as well. So, when we look at kind of the instability that the hospitals are facing right now, I am concerned, and you've been very diplomatic about, kind of the circumstances that you're facing right now. But, the responsiveness of the HSCRC to be able to account for these other provisions, I guess you brought these concerns up before the commission. Have you seen much progress in terms of the changes to the model, whether it's age adjustment, demographic adjustment, accounting for staffing costs that you point out have increased significantly? Have we seen much of the changes that you feel are necessary to take place?
Would you like me to say something?
Just kick me under the table. So, we definitely know that the HSCRC is looking into whether there could be some modifications made to the way that we're funding demographic growth, which is good. And I think, the sooner that we can get on that work and make progress there, the better. We'd like to see more progress on the way that we fund inflation. I think, that's something that we'll continue to press to address those cost drivers. So I will say, the third area is just, there's a lot of interest generally in the way that, we're funding volume growth and also volume shifts. And so we know that there's going to be some good work, some hard work that's going to be put in to work to tackle some of these issues. But it's a lot. And so I think we're encouraged to hear that there's interest in making progress on demographic growth, and we're also glad to hear that there's interest in making progress on trying to help hospitals find a way to recover some of these costs for those physician services that have really been escalating and is not currently a recoverable cost under our rate structure. So those are really two areas where we're hearing some interest from the HSCRC in helping make progress. But we don't have a lot of time. We really need to move as fast as we can to help fix some of these issues.
Yeah, and I think that's where there is the tension is, the urgency. You heard from, President Bayless here that there is this urgency that the hospitals feel because of, the financial strain that they're under. And so the timing of resolution is not moving at a pace that I think the hospitals are comfortable with. And that's where there seems to be the biggest area of concern.
So just to paraphrase that, it sounds like, Patrick, you'd mentioned that there's interest in considering. I'm not hearing any progress. I guess you haven't seen any progress. You mentioned that there's concern about timing. Tight time frame, no progress yet is kind of the translation that we're getting right now. That there's a lot of reassurance, I guess, that this will be addressed, this will be addressed, this will be addressed. Nothing that has changed yet as of what?
Not yet. Not yet.
Of yet. And how important is this July deadline for some of these changes to be taken into account in some of the ahead targets that need to be met?
So the
or established?
The July timeframe is one milestone during the year that is coming up where, the population health, the quality goals, and the health equity goals will need to be established. And so those will take, a lot of work for us to develop, all of those statewide metrics as part of the AHEAD implementation process. And then, in the fall, there will also be work to set all payer targets. And so there's a lot of milestones associated with the AHEAD model. And so what our main message is that in parallel with doing that work, we can't lose sight of these issues. We have to make sure that, again, when we talk about the funding and the resources that hospitals need in order to simply maintain the level of acute care needs that exist today, has to be a priority. And that has to be done in parallel with this work on AHEAD.
So the next year is going to be critical in seeing both the AHEAD milestones be addressed by the department, by the HSCRC, but then also these concerns that have been brought up to be accounted for and updated into the model.
That is correct.
Okay. All the while, it sounds like from Ms. Bayless's testimony that, the hospitals are operating in the red, that, almost half of them are losing money, and the expenses are growing at twice the rate of growth. And so all of that is a significant overlay of concern, I guess, while we're waiting on this model to change. Okay.
And to be clear, Senator, if I could, Madam Chair, we're not just waiting. Behind the scenes, there's data collection and analysis happening. There's, communications with HSCRC on a regular basis. Our teams are working with teams there. We're working with the hospital field to make sure that we capture the concerns of the field and communicate them in writing through testimony. So what you all are hearing today is a culmination of over a year's work, and according to others who predated me in this role, some of these issues have been percolating to the top for some time. It is the implementation of the AHEAD model that has the field deeply concerned that moving into a new model without mitigating the concerns that occurred under the current model is not wisdom. So we're trying to get these things addressed as we prepare for January 2026.
So we're hopeful, and hopefully we'll see some changes.
We're working, Senator.
Yes.
Madam President,
All right,
I have one
thank you.
comment. I think we both maybe bit off a little more than we thought.
I couldn't be in a better place working with better people.
Thank you.
And
I feel the same way. It doesn't
Yes.
mean it's not a lot of work. I don't see any other questions. I wonder, would you like to go now on the emergency department wait times, or would you like for the HSCRC to go first?
Go quickly. Yes, Madam Chair, we're expected in HGO, so I think I'll send a couple of the team members over to that
Okay.
committee and,
Oh, it will be rescheduled?
well, then we'll take our time and talk about ED. You want to stay?
You mean they have more questions than we have?
Do you want the department to come first then?
No, it's up to you, whatever you think. You're already at the table. I thought maybe you'd like to go ahead and do that. I wondered where Andrew was. He was sitting behind the podium. Go ahead.
Madam Chair, before we jump to the next topic, I do think it's important to note that the terms that were negotiated, high-level terms that were negotiated between the state and the feds for AHEAD are actually quite favorable. and take into account some reflection on the past, but we still want to be able to correct these things. So I think it's important to note that there are several terms under the AHEAD agreement. It's 140 pages. It's a lot of detail, yet a lot more detail in the next 11 months. But there were some favorable terms recognizing the performance under the prior years of the model, but that performance has been really, I would say, above and beyond what it needed to be in terms of the savings. But I think there was good progress there.
Thank you. So we're going to start now with the Emergency Department wait times overview. And again, the Maryland Hospital Association will be addressing their issue. Thank you.
Excellent. Thank you, Madam Chair, Mr. Vice Chair. While the slides we have prepared are being queued up, I just want to say at the outset, look, we understand that this is an ongoing and critical problem across the state. So I don't want anything that I'm about to share be interpreted as downplaying the significance of this problem. We know it exists. We are fully leaning into it. Hospitals are on the front lines in the trenches dealing with this issue. What we want to do is really just give a sense of the work that is being done by hospitals in collaboration with one another across the industry and with our regulatory partners, as well as partners across the continuum of care, to help address this issue, and then talk a little bit about some of the particular pain points that are beyond hospital control. Not that we're not leaning into those as well and trying to improve them, but they're just not something that hospitals can move on their own that are particularly problematic with ED wait times.
They're trying to tee up. I've done things all out of order today and gotten everyone confused.
Challenges.
Just give us a second to bring it clarity.
No problem.
Pardon me?
I said, you're the boss, you can do that.
I know, thank you. But I did turn things upside down today, so I apologize for that. We just have to get to your, I think there we go. Thank you.
Excellent. These guys. All right. Excellent. All right, so just an overview of how my comments will be structured. First, I'll give an overview of some of the hospital-based initiatives that are ongoing right now to address this issue, particular specific strategies hospitals are looking at to improve processes internally to address emergency department wait times. Then I'll speak to probably somewhat briefly, because the commission's coming up after us, on some of the policies, public policies that are in place to address this issue as well. And then I'll wrap things up with a look at some of the non-hospital areas of focus that we're being faced with and are also working to address as well. And so really just want to again reassure you that there is work being done, and it is important that these issues are being addressed together in a cohesive way. We're not siloed on this. There is a lot of collaboration in moving hospital-based initiatives, regulatory initiatives, and the non-hospital issues forward at one time, because that is the key to optimizing our processes across the state and hopefully improving and addressing this issue. All right, so some of the hospital-based initiatives that we're seeing. First, MHA brought together the Hospital Throughput Collaborative. This was an internal group of our members from across the state that was really aimed at bringing folks together to share their experiences, share common practices, share industry standards, best practices that they're looking to implement, how they might be replicated. This allowed members to also take into account sort of unique circumstances. As you've already heard, not all hospitals are the same. They serve different communities. They deal with different issues. And so gave a chance for members really to discuss how these different things might look differently based on the populations they serve. Also, a chance to engage across other multidisciplinary stakeholders as well. And so what happened as a result of that collaborative is hospitals really push themselves to identify specific targeted strategies to address emergency department wait times, and those existed in three main areas: input to the hospital, throughput throughout the hospital, and then output or discharge from the hospital. When we look at input, we're talking about strategies around EMS offloading times. Some members have implemented strategies for greeting EMS before they even get in the door, identifying who they've got, what the patient is, and directing them accordingly. Northwest Hospital in Baltimore County has a very innovative approach that, again, they're sharing with other members across the state,
where they direct, the lower acuity patients as they come in on one pathway and then the higher acuity patients on another, so that it's not everybody in one pathway. And that has helped to expedite folks through the ED and more rapidly get them the care that they need. Throughput through the hospital, primarily speaking of throughput from the emergency department into the inpatient bed, obviously critical to this issue, being able to get those ED beds open as quickly as possible so a new patient can get into them. A lot of innovative strategies around here, such as the full capacity protocol, which has been implemented at several member hospitals. This includes when a bed has been identified as going to become available, moving a patient from the ED to that bedroom, even if it's not fully ready for them, having them set up in the hallway, put up privacy screens so they're not just laying there exposed, but they are right beside the room, and it actually improves the patient's experience because something's happening. They're moving, they can see the room they're going to go in, just while it maybe needed to be finished, cleaned, and being setting up for them to go in, and then you get the benefit of opening up that emergency department bed for another patient to then go into that bed. And then output or our discharge processes, things like building out discharge lounges so that folks who are ready for discharge, but maybe are waiting medical paperwork, follow-up orders, and the things to be ready, move them out of their bed into these discharge lounges so that we can more quickly turn that over. So just a flavor of some of the specific initiatives ongoing in hospitals, process improvements to help address this issue. Some of the regulatory initiatives, again, I won't dwell on these since the Regulatory Commission is coming up behind me, but the Emergency Department Length of Stay Initiative, this was a hospital-supported initiative to put our money where our mouth is, basically have put money at risk for improving ED length of stay. Approximately $30 million in hospital funding went into this policy, and again, this was supported by the hospital members, recognizing the significance we place on this issue. The hospital ED best practices policies is something that's happening right now in real time, I believe rolling out very soon, is a collection that will incentivize ED best practices to be established in hospitals throughout the state. And then you may have heard of the EDDI project, Emergency Department Dramatic Improvement Effort. And this is really was work driven by the MHA Throughput Collaborative in identifying some of those best practices and initiatives within hospitals. I'm sure you'll hear more about these from the commission. So now if I could move to the non-hospital areas of focus. And I'll talk about these in three main categories. Infrastructure and systems that need to be improved, increases in preventative and post-acute care, and then finally, workforce issues regarding patient overstays and capacity challenges. So with infrastructure and systems, specifically in our behavioral health system, to say it simply, Maryland does not have enough lower acuity behavioral health beds. And so we really need to improve our care coordination and placement, ability to place patients in the beds we do have. And although it is not ideal, when we don't have a bed in the state, our ability to more quickly place a patient in an appropriate setting outside the state. Right now, that is a very laborious, long process. And I understand, again, not an ideal scenario, but when that is the only option, some process improvements to enable that to happen more quickly. However, ultimately, we would want to keep our patients in the state, and so we'd love to see increased reimbursement rates for residential treatment centers and other community-based settings so that we can have more of that availability here in Maryland and fewer patients need to be placed out of state. And then, of course, we have, finally, an important part is enhanced targeted case management services, and these are wraparound support services that can be provided to patients at home, which is really the gold standard. Many patients who end up in the hospital could be cared for at home if families simply had more resources in order to do it. And so enhancing the availability of those services so that patients don't end up in the hospital in the first place. And then secondly, we would love to see some reform around payer denials, how those are reported, tracked, and reforms aimed at decreasing the number of denials. We have seen a significant increase in denials over the last several years. And to that end, we want to thank Madam Chair for sponsoring an effort to bring together a multi-stakeholder work group over the interim legislatively mandated work group to help examine this issue and hopefully decrease the rate of denials and also increase the transparency and data we have around denials, because right now what's publicly reported is not matching up with what hospitals are experiencing. And this is an area where hospitals and the HSCRC are very well aligned and working together to try to improve that issue, because denials really do, not only do they impact patient care and outcomes as far as their ability to get the care they need, they impact wait times. Because if you have a denial that's a prior authorization, the patient is waiting, potentially if it's a prior authorization to go to a post-acute care setting, is waiting in that bed until you can resolve that issue so they can then be discharged. But even if it's a medical denial, so after the fact, that particular patient may not be in the hospital anymore, but the provider needs to take time out of their day to appeal and address the denial that they received, and that's time they're not able to spend at the bedside, again, compounding this issue. So again, Madam Chair, thank you so much for your support on that, and we hope to drive some improvement in that area. Excuse me. Increasing access to preventative and post-acute care. This speaks to the really inputs on ED wait times from across the continuum of care. We really need to see expanded access to primary and urgent cares so that people can, that's your wellness care, keep you from becoming so critically ill that you have to end up in a hospital. And that's you've heard that mentioned a lot of times under AHEAD, something hospitals are very interested in, expanding access to these services. It's good for communities and the patients we serve. So we are hopeful that expanded access can come. And then also expanded access and care coordination with our partners in the post-acute space, such as skilled nursing facilities and nursing homes. But they struggle with some of the same things we struggle with around workforce. However, we want to maximize our ability to transfer patients from hospitals to those spaces in an expedient manner. And so issues even as much as transportation, which is more challenging on a weekend or an evening than during the daytime, addressing those kinds of issues are things we're working on in that area as well. So finally, kind of a catch-all, we have workforce issues, overstay issues, and capacity issues. Workforce, it's been spoken about already. It's nationwide, significant issue. Got to build up our workforce in the ED, both clinical and non-clinical, and across the hospital field. Hospitals, again, have leaned into this. I believe are up to 11 different hospitals since the pandemic have started certified nursing training academies for nursing assistants, and they are regularly graduating classes. That's a great pathway into nursing, into a full nursing degree where you can be employed and get training on the job as you pursue that higher level. Overstays are a major significant issue for hospitals. These are patients that are stuck in a hospital who no longer need acute care. They do not need to be in an acute care setting. They could either be discharged potentially home or to a lower setting, but there's simply no place for them to go. We see this in largely two kind of categories of patients. We have pediatric patients. Many of them are waiting for that lower level of care I spoke about earlier that we simply do not have enough of in the state. And then we also see that in some of our older patients or other patients that are otherwise in the guardianship process. Again, a very challenging issue. And so the guardianship process is actually going through a statewide work group that's ongoing. I don't believe we anticipate legislation from them this year, but maybe perhaps next year to address that issue. Hospitals are fully engaged in that process. But for the pediatric overstays, again, thank you to the Madam Chair for her support for this issue. There will be a bill in to help address that issue and build our capacity in the state for those patients. And then finally, it's around capacity. Again, a lot was already spoke about that. You've heard about that already earlier. But ensuring Maryland hospitals can accommodate the demands for care that they're facing, especially with the growing and aging population that you heard spoken to. Admittedly, under the model, capacity in some areas of the state was supported. Hospitals that have significant Medicaid or Medicare populations have been supported under the model, but our hospitals that have seen growth rates beyond what was anticipated by the model or the projections are struggling. And there's been a lot kind of said about that already, but just leaning in and helping to address that problem as well. So ongoing right now is the statewide ED wait times reduction commission. I'm a representative. I represent the Maryland Hospital Association on that commission. Hopeful that that can be a venue to drive a lot of these changes. The Hospital Association hosted a commission last year, and so hopeful that under this statewide commission, we can bring a lot of those issues that were identified last year into this group. It is made up of a diverse set of stakeholders from across the continuum of care, and in partnership with our regulators, hopefully an opportunity to really drive statewide change and reform. I think with that, I'll submit and happy to answer any questions.
Thank you, Andrew. Do I have any questions? I think we all know how serious the problem is. We're just looking for solutions.
Yes,
I'm
ma'am.
happy to help any way that I can, but I just so frequently get complaints about that. Senator Reedy?
I wonder, in the spirit of solutions, you just touched on this a little bit, but is one of the issues that we have where people will get stuck in this limbo, there's two issues. One is that we're having a challenge getting treatments approved through insurance, especially continuing care treatments as it relates to cancer and other types of services. And that may not immediately strike people as an ER issue, but it does. It's kind of, when you have somebody sitting in a bed or laying in a bed for an extra 8, 10, 12 days. So I wonder if you could speak to that. I may have one follow-up.
Yes, absolutely. So that's the concern over the increase in denials that we're seeing across the state and across our hospital members, that with more treatments being denied, patients are stuck in the hospital longer, unable to access the care that they need, particularly if you're unable to discharge them. Either they need approval to be discharged, or they simply are not well enough to be discharged until they get that level of care.
Well, one of the things I think I found frustrating, and again, talking to one of my local hospitals about this directly, is it's one thing if it's some procedure that insurance hasn't had the opportunity to kind of decide if the person's insurance qualifies for, but we're talking about basic cancer continuing care for cancer treatments in many cases. It's like, that's not controversial. That's not somebody asking for like some sophisticated elective surgery. So has the Hospital Association been able to interface with insurance companies at all to try to, have there been any conversations in that regard from the sort of the association level?
Yes, so actually we just took part in a work session 2 weeks ago, I think. Actually, the chair of HGO convened a session that had a multitude of stakeholders from hospitals, insurers, MIA, MDH, to talk through these issues. I think these discussions are just getting going, really, in trying to hash out these issues. As we've seen, there is a dearth of data around this. So hospitals can track the denials that they are experiencing, and over time how those denials have risen and where the denials are occurring, whether it's in the ED or inpatient or for this service line or that service line. We don't know things like how many are being overturned on appeal. They don't track like that.
You mean, I'm sorry, the insurance companies don't track?
I think they do, but we don't have that. And so that's where we want to get to, is having that more readily available so that we can all see that and understand the full scope.
Right, because as I've talked to like my hospital CEO, it's like if there's a paperwork issue, well, let's figure it out. Right. But it sounds like it's more than just that. And then one final follow-up. I don't think people, and I didn't understand this when we first started talking about emergency room wait times the way I guess I should have. It's all the way up and down the chain. So you also have people sitting in a hospital or laying in a hospital that are waiting for acute care, right, at long-term care facilities, and we just don't have the space in a lot of places in the state. Is that a major factor as well? And I guess that's a thing we need to find a solution for. I feel like on the other issue, if we could really figure out where the bottlenecks are on the insurance approval process, that would help some. But I don't know if there's, I guess I'm just commenting. I know that's an issue too, is where do you put people who need that 2 or 3 months or 6 weeks or whatever in a facility. So I guess that's just something we need to continue to work on. But thank you.
All right, I don't see any other questions for this panel. Senator Lamb?
To touch on what you're saying with ED wait times and the new AHEAD model, I guess, just trying to understand the intersection of those two, kind of issues that we're working through right now, that with the new AHEAD model, obviously a push to reduce hospital utilization, right? And, when talking with hospital CEOs, folks have said that, they're now incentivized to see fewer cars in the parking lot, fewer beds, right? And so, on the other hand, when we see, the ED wait time issue, and obviously this is very complicated, it's multifactorial. Part of the issue that we have heard is just inadequate number of beds. And so, that tension there, I think, is really difficult to kind of get at and get that titrated correctly so that we're not negatively impacting hospitals through the work that we're doing with AHEAD, which is important and necessary, but also trying to not impact this in a negative way too. Can any of you speak to that intersection?
I can. So I guess I would just offer a little bit of perspective. Thank you for the question. There's variability across hospitals. I think there's physical beds and then there's staffed beds. And there are some unintended consequences of the model where the more you're growing, the less reimbursement per case you're getting, and your margin deteriorates. So what we're seeing is fast-growing hospitals are having real margin deterioration, and hospitals that have reduced their volumes or shrunk have that, what we call sort of excess revenue, if you will. If everyone was going down, everyone would have excess revenue that could then be invested in these population health initiatives. So there's variability. So you'd have to say, are all the beds staffed? Because it's different. If you're having to incur massive agency expense and premium labor to staff your beds, you're stuck trying to figure out how to maintain access while offering. So if in 2 acute care hospitals that I lead, every bed is open and every bed is staffed because we're growing, but we still have challenges in the ER with wait times and the like. We have problems with denials. It is multifactorial, but I think there's probably some variability under, are all beds in the state staffed? There's physical beds. Mm-hmm. Can you afford to staff every bed? And with the labor costs not being fully funded through the model, it's very difficult to afford a 38% increase in your staff over a 6-year period. I would say on the issue of denials, it's very complicated, the issue of denials. And we know big picture numbers that hospitals experience a 19% denial rate, aggregate denial rate by payers. That's a national number. It's also a number here in Maryland. We know that denials have gone up by a factor of 3 over the past few years. So it is a way to avoid paying for necessary care. And I can't imagine that any of us would agree that 19% of the care provided in hospitals was unnecessary, inappropriate, or not worthy of payment. And when you get in that jam of you're trying to discharge a patient to a post-acute setting, is it that there aren't enough beds, or is it that the owner-operator model in the for-profit sector of post-acute care, they only want certain kinds of patients in their facilities? So there's a different conversation in the post-acute space. I'm not sure if there's agreement. I did hear the health secretary say this, and we could probably delve in a little bit further. What is the level of shortage in post-acute beds? But it's kind of a double whammy. The patient's in the hospital getting care, isn't going to qualify for acute care hospitalization, but is not being approved for discharge to a facility. So you're caring for the patient, not getting paid. The payer's not paying for the level of care needed because the post-acute facility won't accept the patient. So and the hospitals don't always have the level of control on that, full continuum into the post-acute space. Right. So there's a dynamic, and I believe we've demonstrated that Maryland has a disproportionate share of for-profit, private equity-backed post-acute facilities.
Yeah, I was going to say
versus other states.
We're seeing more and more of these post-acute facilities being bought up by private equity. So they may want to cherry pick or pick certain patients that would come in and not others, and that backs up your ability to discharge them out. Right.
I would just add that is one of several factors that we hear about from the hospitals. When we talk to our members, what we see is that when they're in control of the patients and their ability to move through the system, they are very effective at being able to achieve sort of the expected wait times as compared to national standards. It's when you start to introduce all of those other factors that we've been talking about, whether it's ambulance transport, prior authorization, guardianship, post-acute services. So all of those things that are really outside of the span of the control of the hospitals, that's where you start to get into the much longer wait times. And so to Andrew's point, I think one of the things that we are really excited about is the opportunity to be a part of the conversation on the ED Wait Times Reduction Commission, because it really does bring together multiple parts of the healthcare spectrum to look at this issue, recognizing that it manifests in the hospital, but it really is a result of several different factors coming together across the healthcare spectrum that need to be addressed.
Great. All right, thank you.
I don't see any other questions. That ends this panel. Thank you very much. And our very last briefing of the day will be HSCRC with the Maryland Emergency Department wait times. Nathan's going to look for your slides.
Oh, okay, wonderful. Thank you. Thank you for the opportunity to come back up. Thanks. We're going to, again, take a kind of tag team approach here to walking through a number of different factors here. Want to start, though, with just, kind of a statement of the problem, right? We've come before the committee in the past to talk about, thank you. To talk about ED length of stay. Obviously, this has been a long-standing and really kind of critical concern for our acute care delivery system here in Maryland. As you can see from the data, it stretches back as far as our data go, right, that we've had high lengths of stay, which is why I think, as you heard from the previous panel, we are collectively putting a lot of focus on this, and then also really considering the multifactorial nature of the problem in a way that I think other states have not. So I want to kind of outline some of the multiple factors at play here so that we can have a kind of collective understanding. We kind of think about this within the HSCRC as breaking along kind of three buckets, right? So one are key hospital factors. Institutional complexity is on here for a very important reason. The hospitals in Maryland tend to be bigger and provide more complex care than hospitals in other states on average, right? So we have a number of highly complex hospitals. Why is that important? It is important because it's important to understand that as a baseline, right, that is an appropriate thing for the overall care delivery in the state, but it is going to be a headwind in terms of how much we can improve ED wait times, right? But these other factors, I think we have a lot of opportunity to move and make up some of that gap, right? So we've talked a little bit about hospital capacity. Again, I think it's important to break that down into component parts, right? Certainly, bed distribution and type, we've talked about that quite a bit. Some hospitals need more physical beds. Some hospitals need different beds, and beds may need to be distributed differently across the state. Length of stay, I think, again, we've seen even over the last year, individual hospitals making big strides in reducing length of stay and having that inpatient length of stay pull through to big gains in ED length of stay. And then staffing, we've talked about that as well. And I think President Bayless mentioned it well, right? We have hospitals that take different staffing strategies for various reasons across the state. That has an impact on the overall capacity within the state. ED volume is another big factor, right? So again, the volume that enters into a hospital, obviously that impacts the ED length of stay, and quite frankly, we have different hospitals bearing kind of different levels of volume for various reasons across the state. So this is related to capacity, right? Non-hospital factors, we've, in our work with stakeholders, we've certainly identified a number of areas outside of hospitals that we'll talk more about as really important kind of areas where capacity in those settings then impacts hospitals. And then additional factors, right? End-of-life care being conducted in the hospital, teaching status, urban service areas. These are all, they're not as impactful on the overall picture, but they're certainly important factors that we have to keep track of. So I'm going to talk a little bit about some of the things that the prior panel mentioned in terms of things that HSCRC is doing, and then I will turn to the Secretary for work that that the department is doing, and then Tina, who will introduce herself in a moment, will talk about the ED Wait Times Commission and the work that is slated there. But a couple things over the past year that we've really ramped up at the HSCRC. One is the couple collaborative efforts that we've done with the Maryland Hospital Association and other hospital partners to really drive greater focus and quality improvement efforts on the ED experience for patients, right? So really looking to identify, share best practices, and then identify common pinch points for ED operations within Maryland. And one of the really important benefits that we've gotten out of doing that work is we've got much more consistent reporting on ED wait times across the state. That's critical because we need to have apples to apples comparisons as we continue to do this work. One really important and very tangible thing that we've done is we've added ED length of stay as a major component in our overall quality program within hospitals. So that means that a higher proportion of revenue is at risk for a hospital's performance on ED length of stay. So this is an important tool that the commission has kind of traditionally applied, right, is to incentivize those outcomes. So that work continues. That is new this year, and we'll continue to evolve this over time. So let me turn to the Secretary.
So I'm just going to spend a few minutes discussing what we are working on. You've heard a little bit about all the work the department's doing related to primary care. We'll spend a little time talking about 1915I, mobile crisis and crisis stabilization, and then our ACES expansion with some community wraparound supports for persons who are marginally housed or homeless. So the first is our 1959 services. So this is the enhanced targeted case management that was just mentioned by the Maryland Hospital Association. And this was flagged early in my tenure in the administration at a meeting at the Maryland Hospital Association. And what we learned is that the department or the prior administration didn't do a good job on submitting this waiver application. And the barriers to accessing this service were pretty high. And so families, quite frankly, just gave up. And so the number of people in this program was very, very small. And what the program does is it provides intensive in-home services, respite services for families that are struggling, just to give them a break from the child that's struggling, family peer support and experiential and expressive therapies. And so over the last 6 to 9 months, we've been revamping the 1959. It's been out for public comment, and it is expected to be submitted to CMS early February, and then they'll put it out for a 30-day public comment period, but we're hoping to take this program live Q4 of this year. That means we will be offering every tier of the enhanced case management services, tier 1, tier 2, and then the wraparound services. And we're going to be going from, I think the threshold under the prior waiver was about 200 children. And I will tell you, when I took over the administration, there was only about 32 kids in the program, again, because the barriers were so high. So they ended up crashing into the ED for services. This will serve almost 3,000 children and their families. So it's really exponentially more access. It's funded in the budget, and we are just waiting for CMS approval to do this. So this will have a significant impact on our kids with severe emotional disturbance and families that are struggling. The key proposed changes in the waiver will be to increase the time frame that a face-to-face psychosocial assessment must be completed or updated to within 60 days of submission, expand participant eligibility to include a score of 2, expand participant eligibility so participants who receive a score of 5 or higher do not have to meet additional needs-based criteria, update the frequency for point-of-contact reviews, remove the separate reimbursement for telephonic peer support service, and then add coverage of youth peer support services. So we're really opening the floodgates on this program in an effort to enhance services for kids and their families that are struggling. The next one is access to crisis services. So urgent and acute care service continuum on the behavioral health side. So again, as I mentioned, many people with or children with severe emotional disturbance or even adults use the ED oftentimes as their main point of contact when they're experiencing new symptoms or more complicated behavioral health systems. So we have the 988 helpline now, someone to call. We have community-based mobile crisis response teams. We've expanded the number of mobile crisis teams statewide. We've also expanded the number of brick-and-mortar crisis stabilization centers, and then expanded post-stabilization support and care coordination. On the mobile crisis team, it's in-person support by a team, including licensed behavioral health professional and often a peer. It's available 24/7, 365 to go to the individual in the community. They provide services to de-escalate, assess, stabilize, and make warm handoffs to treatment and conduct follow-up. So they try and connect them to behavioral health services immediately. Now, unless someone has to be EP'd, emergency petition, and has to go to the emergency room, the goal is to stabilize them in the community, get them treated in the community, and keep them in the community. And certainly we want to support evidence-based youth family response and stabilization model. Then lastly, I think many of you know Assistance and Community Integration Services. We had a pilot that started in July of 2017. It provides housing and tenancy-related services and supports to qualifying individuals. Local health departments or local government entities were eligible to apply, and Medicaid participants had to have a specific health or housing need based on criteria. When we started the program, there were 900 spaces allocated across Baltimore City, Cecil County, Montgomery, and Prince George's County. And now we are going statewide. We requested an amendment to CMS, which actually was just approved, I think this week or late last week. It included $5.4 million in state general funds, and then we got the enhanced match from the federal government. So it will allow all jurisdictions to bill. Now, the 4 jurisdictions that I mentioned, there were matching dollars, but now the state will be supporting all jurisdictions, and the number of spots, it'll allow for an additional 1,240 spaces in the program. So statewide with enhanced supports, which will help to facilitate keeping people out of the emergency room. So I went through 3 programs pretty quickly, but we're working on a bunch of other initiatives, including looking at post-acute transitions of care, and then certainly end-of-life care. We have one of the lowest referral rates into hospice in the United States, and our length of stay in hospice is significantly lower than other states. And when you ask people where they want to die, it's not necessarily in the hospital or in a hospital ICU. So lots to do in the post-acute and end-of-life space. So with that, I'll turn it back over to the HSCRC.
Hi, good afternoon. I'm Tina Simmons. I'm the Associate Director of Quality Methodologies at HSCRC. And I was given the opportunity to be the project leader for the ED Wait Time Reduction Commission and subgroups. And I just want to say this is something that's near and dear to my heart because I am a trained emergency department nurse and spent several years doing that before I transitioned into other roles in hospital quality. But I've spent 20 years working in hospitals prior to my transition to the HSCRC. So the slide is just an overview, which I know you're very familiar with, of the ED Wait Time Reduction Commission. Really the specific focus, the areas that we really are cued in on are ensuring patients are seen in the most appropriate setting, the pre, intra, post-hospital. Overall goal is to improve efficiency, improve post-discharge resources. Really important opportunity that the Commission affords is for us to identify and recommend improvements in the collection and submission of data. And as I'll talk about in just a minute, that's an opportunity that we are taking advantage of to try to identify opportunities outside of the hospital, which has not been within our scope to look at that data previously. And then finally, to facilitate sharing of best practices. So this is just an idea of the representation on the Emergency Department Wait Time Reduction Commission and the subgroups. Many of the roles for the commission, the roles were determined as part of the bill and identified the type of role that should be on the commission. However, with our subgroups, we have additional agency representatives, hospital representatives, and some of our other partners. The key takeaway from this is really that there's such a diverse group because this is really a multifaceted issue that's very complex in nature. This is our visual representation of the commission. Overall goals are to improve access, implement hospital payment programs to improve clinical care, as that is our lever at the HSCRC, increase transparency, and reduce avoidable utilization. But the real takeaway is that we really just want to provide the right care at the right time in the right place. So these are the 4 subgroups that we have established through the commission. These were the initial ones identified. The first is access to non-hospital care, and we are really looking at those things outside of the hospital that impact throughput, which is kind of the care transition that starts in ambulatory care with your primary care, your specialist, that goes through the hospital and then transitions to subacute care or palliative care outside of the hospital. And this group has identified its priorities. 3 top priorities are post-acute skilled nursing and palliative care, advanced primary care, and access to behavioral health care. The data subcommittee really runs through all of the groups. This is where we're pulling together all of the disparate reports that we have access to from the hospitals, that we are now accessing from other agencies, from other vendors, and it will allow us to pull together a complete picture across the continuum of care for the patients. The ED hospital throughput best practices, as our colleagues from MHA shared, has been ongoing. We do have a draft proposal. The final will be presented to our HSCRC Commission in March. This is very heavily staffed by hospital representatives, and they actually have been working very collaboratively to identify these best practices. And the intention is really to improve throughput throughout that entire hospital process. And so we are building the infrastructure, developing this with the plan at the end of the year to really identify which best practices could be appropriate for a pay-per-performance incentive program that would then incentivize these hospitals to further implement. And then the hospital capacity operations and staffing. It will convene in April. We have been doing work to identify stakeholders for this group, and I have a running list. And really, we're pulling a lot of the data that we are working on identifying capacity, staffing, operations issues, and that's where we'll really break this down. The access framework that John mentioned earlier will really be a key focus here. And we're really looking at some of our key opportunities, looking at capacity in the sense of number of beds, types of beds, as well as that length of stay component that John mentioned, and trying to break that out into what is operational at the hospital, what can we link to the payer denials, and then what can be attributed to the care transitions to that post-acute space. So the key priorities that we have identified to focus on in the commission is the hospital throughput and the ED boarding, looking at optimizing capacity across the continuum of care. So looking at, do we need to focus resources in establishing, beds in crisis care outside of the hospital versus also the capacity inside and then in the post-acute space. Care transitions within the hospital, that's that length of stay piece that I mentioned, and that can be within stakeholders and various specialty groups inside of the hospital, as well as the post-acute, the palliative care. Our commission timeline, this is the high level bullets, but the bill went into effect July 1. We worked to identify stakeholders, accepted applications, and the secretary appointed the members. We had our first meeting in October and have ongoing meetings, which is there are deliverables for the commission in particular, are a report of findings on November 1st, 2025 and November 1st, 2026. But that middle bullet in between, that's just one point there that says November 2024 to October 2025. Just want to highlight the amount of work that these members are doing. So our calendar year 2025 schedule of meetings related for the commission, the subgroups, and then our related groups at HSCRC has 54 meetings on it. So there are there's a lot of work ongoing and a lot of focus on this, and just wanted to share that with this group. Thank you.
Thank you all. So I just don't understand how Maryland, with the great healthcare system that we have, could be 50th on the list of ED wait times. And we keep having meetings and bills. I mean, it's been like 10 years. The legislature has been putting together work groups and meetings. And I feel like here we are again. So I hope we're not going to wait until the final report to see changes. I hope that we're going to be making changes along the way. I asked when I worked on the first commission, we're the only state in the country that had an all-payer model, and we were the only state that was 50th in the country in ED. Is there some relationship there? What is it that we're doing that puts us so far down on the ED wait times? It's very frustrating for all of us, with us personally, for our families, for our constituents. It's just, I just don't understand.
Yeah. If I may,
Please.
I think, Chair, I think two kind of important aspects of this, right? One is, yes, we share the frustration, and we will not be waiting until reports, et cetera, to take action. I think you heard from the Secretary some of the kind of concrete steps to provide access out of the hospital, outside of the hospital, that will depressurize some of the ED lengths of stay. I think we are taking those kind of preliminary steps now, adding incentives into hospital global budgets, ensuring that we have some standardization of best practices across hospitals. That will also certainly help in the short term. Over the longer run, because it does take time to build capacity both in a hospital and outside of a hospital, building workforce, et cetera, those are longer poles in the tent, but certainly, again, precursors to that. We need to take action, certainly in advance. To the point about this challenge persisting within the model, first I would say, again, this existed previous to the model. One of the challenges that I think we would be facing absent the model, I want to be very kind of clear about it, right, is we talked about the things that the AHEAD model preserves. One very, very critical aspect of that, can't stress it enough, is the federal dollars that flow into our state. Absent the model, right, the counterfactual of the model not existing, we are not going to be in a position to make the investments that we need to make. We will be hunting to backfill those dollars, right? And so I want to make clear that, within the model, we do have opportunities, and we need to take advantage of those opportunities. And that's, I think, where we're going to see some progress over the coming year.
Dr. Crum, can this administration take away the whole all-payer model? Can they just say we're going to eliminate this program?
So technically, yes, but just to give you an idea, back to the enhanced payments that the state receives from Medicare, those would go away. And then typically in most states, payers pay the most, commercial payers pay the most, then Medicare, then Medicaid pays the least, which is why you have safety net hospitals in other states because of the payer mix. So not only could we see hospital closures, but certainly worsening of the budgets as each hospital negotiates new contracts with Medicaid, Medicare, and with commercial, because that all-payer rate would go away. In addition, you would compromise access. Again, back to the revenue mix that hospitals have. Many hospitals that have a larger number of Medicaid and Medicare beneficiaries tend to have much smaller margins without enhancing that revenue some other way. So there would be access to care issues as well. So it could destabilize the entire healthcare system of Maryland.
So, and then into, I'm
No, I
sorry.
was just going to say, Madam Secretary, I think you need to push the button on your mic. Okay, thank you. Dr. Crum.
Sorry, if I might add as well, some of, as President Bayless mentioned, we have a number of terms within the state agreement that are favorable relative to the current state agreement. That's in large part to help de-risk some of what you described, right? So couple kind of key aspects of this. One is the reason why it's important to enumerate the reasons or circumstances under which the federal government could terminate the model is so that we can avoid them, right? That they won't be arbitrary. They will be targets that we will track and have methodologies for. The second is that the principal way in which we could in the past be terminated from the model and then, going forward as well, is missing that that all-payer, the Medicare fee-for-service target. One of the things that's critically different about this upcoming model will be that we have more flexibility to, without tripping the requirements of the model, go over cost growth in the nation for Medicare fee-for-service. That didn't exist under this current model, right? So in other words, if we went over trend in nation, we would immediately start to trigger consequences for the model. We have more flexibility and run rate to make those adjustments over time within the next model. So those are the types of things that I think we've looked at to try to de-risk some of what you described.
Thank you. I see a question from Senator Lamb.
Yeah, and just to I guess follow up on the chair's question, there's also a provision in there that if the AHEAD model, which is what we're moving into now, or is obviously already been signed, if that's severed, for example, there's a 5-year wind down rollback process, I think, built into the AHEAD agreement, right? So to answer the chair's question, that is also a methodology to de-risk this so that, if for some reason the new administration says we're going to stop this AHEAD model, there's still a 5-year runway for us to land this.
That is a absolutely critical point. I think that's the third leg of the de-risking stool, right? And so how that works is, if the federal government decides to terminate, we do get this 5-year runway. Now, I want to level set, right? That 5 years that's an extremely tight timeline to pivot the entire acute care delivery system. But it is 5 years, whereas today we would get 2 years, right? So I think that is an important aspect of it. Thank you for mentioning it.
The AHEAD agreement, though, with that was signed does include provisions, I think, for any hospital to not sign on to this agreement, right? Can they decide not to participate in the AHEAD model?
So the component that is the agreement between the hospital and CMMI or CMS, the component of it that they would be agreeing to is accepting that payment waiver, right? So in other words, it's the thing that allows the hospital to take that differential Medicare rate that the HSCRC would set for them, right? So if they didn't sign on to that, they wouldn't receive that additional payment.
Got it. And the last question, I guess, with regards to these ED wait times that, we've been seeing and hearing about quite a bit. There are a lot of factors that are beyond the control of hospitals. We touched on some of those earlier. Acute care facilities for them to be able to discharge to, inadequate primary care, for example, and many, many others. But when I'm looking at like this quality-based reimbursement program, there's actually downside risk built into this for hospitals, right, that actually touch on ED length of stay. I'm curious why you think that hospitals should be, financially at risk, downside-wise, financially, when it comes to ED wait times, when there's so much that's at play that's outside of the hospital.
In large part because there is a component, right, that does exist within a hospital. I mean, we see it in the variance across the system today, right? Some hospitals perform better. Some, MHA, the previous panel really described some innovative practices. We'd like to see those implemented across all of our hospitals in Maryland, right? There's some hospitals that are doing just incredible work to improve the efficiency of their operations. We'd like to see that across all the hospitals. So there is some opportunity. I think the reason why we've been cautious, both in terms of how we measure it, in terms of how we're counting improvement versus attainment of outcomes, right? That's an important distinction. How we've kind of stepped into that incentive is in recognition of the fact that there is a good deal of this that is outside of the hospital's control, but we are trying to address those components that are within the hospital's control as well.
Got it. Yeah, we'd continue to urge just kind of caution along those lines, because obviously there are a lot of exogenous factors that are beyond their control. You know, there are already many strains, as we kind of touched on earlier, with assessments that are coming into play, and et cetera, et cetera. You know, just noticing that there is downside risk to them here, and that just needs to be continued to be something that we should look at, right?
Yeah, absolutely. It's something that we always kind of step into very cautiously before we.
Thank you, Senator Land. Senator Mounts?
Thank you, Madam Chair, and thank you for all the testimony. There was one thing that didn't come up in the testimony about the emergency room waiting times, and it struck me because I did a little search on Google listening to the testimony, you know, and I wasn't shocked, but it hurts to read it. But, you know, and I'm not picking on my hospital because it's my hospital, and we're going to build a new one, which is much needed. But I just, you know, want to reiterate, I mean, in September, the median wait time at Shore Health was 24 hours in the emergency room. And, you know, when people say that they know the feeling, you know, and they're upset about it, they really don't know the feeling until that's their hospital. And I think that part was kind of left out of the testimony about fixing the emergency room wait times. I think that new hospital, the new regional hospital on the Shore, is going to go a long way to improving those wait times. But as you discuss these things, they're urgent and they're, you know, ongoing right now. And so whatever solution, as minor as it may be, 30 minutes, an hour, or whatever, you know, there's an entire population that serves 4 or 6 counties. Senator Hershey would probably correct me on that. But, you know, you're talking 24-hour wait time, whether you're have an open wound or you have chest pains. I mean, that's a, you know, when you talk about switching from the all-payer system to a breakdown in healthcare, what is a 24-hour wait time? That is a breakdown in healthcare. I just ask you to consider that as you're weighing all these things.
Absolutely. It's a great point. If I can kind of, you know, speak for our partners out at Easton, they are, you know, certainly not waiting for the new hospital to make improvements. And I think they are an example of a hospital and a health system that are taking some real proactive measures to improve kind of their throughput within that hospital. There's also another particular aspect of that hospital or that group of hospitals, which is they are counting
Their transfer time from the freestanding to when you're talking about the admitted patients, because it's time physically. This measure too, when we are reporting for the EDDI, we're reporting time from when they walk into the door to time that they physically leave the emergency department.
Believe me,
for that ED length of stay.
Believe me, yeah, I know it very well.
Yeah.
I know it very well. And there's no, this is not a shot. I mean, we are working very closely with everyone at Shore Health, and they're doing everything they can with the resources they have. But in this presentation about emergency rooms, I just think that's an important point to bring out. And hopefully that will bring a big change for a large portion of the Midshore. So I thank you for supporting it, and I just want to raise it and make sure, just to, you know, these discussions are very informative, and everything sounds good at the end of the discussion, but when you look at the numbers, it's 24 hours wait time, and that's a reality for citizens throughout my district and District 36 and other places. So, but I appreciate it. Thank you.
Thank you, Senator. I don't see any other questions for this panel. You're finally off the hook.
Thank you, ma'am.
Thank you all very much.
Thank you.
We need just a couple-minute break while our manager switches to our bill hearing system, so don't go anywhere. If you do